Hello, hi everyone. Sorry for the small delay that happened. That is because of the network issue over here. So sorry for that. So I think we have been discussing very nicely. So suddenly this kind of network issue has happened and we had to cut a little bit. Sorry for that. Anyway, let us start again. So from where we left again. So I think where I have left, any idea? So where we have been discussing. Where have been discussing, any rough idea? 11. Okay, fine. So human element. So in element, I think I have told a little bit on atrophy also. So why the muscle goes for atrophy and then they go for flaccidity, and why you do get fasciculation fibrillations. We'll be discussing quite after some time. Don't worry about that. And you know what is the type of spasticity you get in the heading of human? That's called a clasp knife spasticity. You know that. So what is the reason why you develop clasp knife spasticity, and what is called as clasp knife spasticity in the first place? What do you mean by that? What do you mean by that word? I mean, that is because of the Golgi tendon organ reflex only, the way you get that sort of a clasp knife sort of a thing. So first of all, as far as the human is concerned, you're not going to get uniform increase in tone of all the muscles. We have already discussed that there are certain groups of muscles that are innervated more by the upper motor neurons, like in the sense by the corticospinal tract. They are more into it. So for example, you take the extensors and abduct of the upper limb and the flexors and adductors of the lower limb. For example, you can take extensors of the upper limb and the flexors of the lower limb are the ones that are typically called as human distribution. So whenever you lose a corticospinal tract, that human sort of distribution, you're not going to develop a full-blown increase in tone of all the muscles, all groups of muscles, which means you will have only increased tone of flexor group of muscles because the extensors become weak in the upper limb, and you're going to get a little bit of increase in the extensor tone compared to that of the flexor group of muscles in the lower limb, because the human supply the flexors of the lower limb. So you'll get a flexor increase in tone prominently compared to that of the lower limb, where you get the extensor group increase in tone. So this is what we refer to as something called a flexor spasm or flexor spasticity, and in the lower limb you will get an extensor spasticity or an extensor spasm. And that is because of the loss of corticospinal tract related innervation to the muscles. And whenever you don't really get involvement of all the muscles in this kind of increased tone, that's where you're going to call this as spasticity, which means all groups of muscles will not be involved in this hypertonia. So only selected group of muscles will be there. That's what we call as spasticity. And what you mean by this clasp knife spasticity, why you do develop this clasp knife spasticity is because of the that Golgi tendon organ reflex. First of all, what really happens is like whenever corticospinal tract is not there, when you're trying to stretch a muscle without the idea of the corticospinal tract, so corticospinal tract can't do anything in that situation, but the stretch reflex will get more and more hyperactivated. So suppose if the limb is like this and you're trying to stretch the limb like this, you will feel an increased tone. That is because like of the reflex act that is continuously working without the influence of the corticospinal tract to oppose that kind of a stretch. So that's what happens. So over a period of time, what really happens is when you stretch too much, so after some time, that too much of stretch will behave as a stimulus for the 1B neurons, that is the Golgi tendon organs that is present over here. So that too much stretch as a protective response, now the Golgi tendon organ reflex will start, and they're going to basically act through the inhibitory interneuron, and they're going to downregulate the anterior hornsel activity, and the stretch will decrease basically after a period of time. So this initial increase, because initially when you give more and more stretch, your reflex arc will become more and more strengthened so that you will get more and more contraction. So it will be too much to oppose initially. So initially you will have so much of resistance. At one point of time, it will give away. So this is what we typically refer to as a clasp knife kind of a spasticity, that is due to a combined action of the simple stretch reflex versus the inverse stretch reflex, which is happening hand in hand together as a single entity. So now you'll understand why you really do develop a clasp knife spasticity. But as far as other extrapyramidal involvement is concerned, so for example, you take a Parkinson disease, you do develop rigidity. What do you mean by rigidity? You develop increased tone or hypertonia of almost all the groups of muscles in the body. So that is rigidity basically. So you don't really develop only one group of muscles in a place. Almost all the groups of muscles in a particular place are uniformly involved in that kind of a rigidity, which we'll be seeing subsequently. For example, in a Parkinson disease, you will get a typical cogwheel type of rigidity, whereas in other kinds of extraabdominal disorders, you will be resulting in a lead pipe kind of a rigidity situation. And whatever we have learned till now is the basic understanding, because that is the one that's going to tell you what is the difference between axonal type of neuropathy and a demyelinating type of neuropathy. Because we know whenever you get a demyelinating type of peripheral neuropathy, it's all about the, where is that? It's all about the myelinated fibers. Whatever that has more myelin are the ones that are going to be affected more in the setting of a demyelinating neuropathy. So similarly, whatever that doesn't have much of a myelin will be the target for the axonal type of neuropathy usually. So that's where the idea is. So whatever fibers that are larger, in the sense like whatever fibers that are having more myelin is the one that's going to be the target for demyelinating neuropathy. Of course, we know that. And typically, small fibers can also be affected, but to an extent, large fibers also can be affected. But small fibers are the ones that typically are target for axonal type of neuropathy. So basically, if you want to tell what are the fiber groups that will be predominantly affected, A followed by B, but A is the one that is typically susceptible to the demyelinating type of neuropathies. But as far as axonal type of neuropathy is there, all the type of fibers, for example, C, B, A, all these things are basically going to be a target for axonal type of neuropathy, even though that C fibers are the ones that are very, very important, that are going to be damaged in the setting of a axonal type of neuropathy. See, remember, as far as the demyelinating type of neuropathy is concerned, we are talking about the diameter of the fibers. So the larger fibers, larger I mean diameter. So that's the one that will be affected in a typical demyelinating type of neuropathy. As far as axonal type of neuropathy is concerned, it's going to be more of a length dependent. So let me tell you what you mean by length dependent. So length dependent means like the lengthier the fibers. It should be small usually, but it can affect all the fibers to an extent, but it's more of a length dependent kind of a nature, in the sense like the more longer the fibers are, more susceptible to axonal type of injury. And please understand that there is a considerable overlap between these axonal and demyelinating neuropathies, and at the same time, a lot of clinical disorders can present as both axonal and demyelinating in a combined fashion. But to start with, you can understand demyelinating is more of a large fiber related problem. So it's going to affect more of large fibers, because those that with myelin only will be susceptible. Whereas axonal, even though can affect all the fibers, small fibers are predominantly involved. But more than the small fibers, the most important word that will be considered here as very important is the length dependent nature, which means they are going to affect the longer fibers. In the sense like the longer the fiber is, the more susceptible it is to development of axonal type of neuropathy. And please don't mistake me by telling that there is a considerable overlap between these two disorders. And more often, since I told you this is length dependent, that axonal type of neuropathies, most often the demyelinating type of neuropathy will be more focal and segmental, in the sense, focal in the sense there might be multifocal also, which means they can affect certain particular area. There will be an area of demyelination, and then there will be a different area where there will be a foci of demyelination, where there will be a different area where there will be a foci of demyelination. So it will be moving on like that. But as far as axonal is concerned, more of it's like a degeneration of the neurons. We tend to call it as a Wallerian degeneration when there is a trauma. Similar to that, there will be something like a degeneration of the neurons. That's what is going to happen in the axonal type of neuropathy. And as far as what are the typical clinical picture that's going to result as a result of axonal type of neuropathy is the sensory problem. Sensory issues are going to be the prominent in the setting of a axonal neuropathy. That's why most of the patients with axonal type of neuropathy will have a problem in the pain and the temperature. So that's the usual problem. The sensory loss is more problematic here. Whereas demyelinating is concerned, most of the large fibers, if you see, they are A alpha, 1A, 1B. So a lot of fibers are involved in the motor supply, right? So predominantly they will have motor issues compared to the sensory issues. So which means I can write sensory issues more than motor issues. Here the motor issues will be more than the sensory issues. The primary problem as far as axonal is concerned is going to be the sensory problem. The pain and temperature loss, numbness, negative symptoms is going to be the most important problem. And most important problem in a demyelinating neuropathy is going to be the motor problem, like weakness, atrophy. So these are going to be the problems. So, but still, you do have some motor issues with the axonal problem. Suppose if you want to really explain these motor issues, how can you explain? So usually these motor issues will be present in the areas of sensory distribution only, which means wherever there is sensory loss, there will be motor issues, which means it will be limited to the areas of sensory loss. It will not be extending beyond the areas of sensory loss. Wherever the sensory loss is, in that area, you will have this kind of motor issues, like weakness, a little bit of reflex loss can be there. But sensory issues that you see in the setting of a demyelinating neuropathy is more of a large fiber sensory loss, which means large fibers carry that posterior column sensations. So that sensation may be lost, but that's not typical, but the motor is more typical here. As far as the motor loss is concerned, it will be usually multifocal. Most of the time, it will be generalized as well. So that's one difference. Here, the motor issue is more limited to the areas of sensory loss, but here the motor issue is generally multifocal and generalized, because in demyelination, it will be like different areas in the body will go for demyelination. At the same time, as far as the sensory issues concerned in the axonal neuropathy, that will be very typical, because these are basically length dependent. And you know, the longer fibers, where are the longer fibers? The lengthiest fibers will be in the fibers that are supplying the feet. That's going to be the lengthiest fibers. That is why most of the axonal type of neuropathies will involve the feet first. So that's why the feet sensor loss is extremely common in this kind of a setting. And at the same time, later on, they can start involving the hands. Once they come to the level of the knee, so now the more longer fibers means your hands also will start getting affected. So this kind of feet and hands type of a sensory loss is what we refer to as a glove and stocking type of a sensory loss. So it's a very typical of an axonal neuropathy, because they are length dependent. The more lengthier the fibers are, more susceptible to axonal neuropathy. So that feet will be affected usually in the first place. Then after that, slowly it will come to the level of the knees. Once it comes to the level of the knees, the sensory loss will start involving the hands also. So this is what we refer to as something called a glove and stocking type of a sensory loss. It's more length dependent. The more lengthier the fibers are, more susceptible they are to axonal type of neuropathy. And because they are involving more of the smaller fibers, so they'll be having more of a vague, dull, kind of a funicular type of a pain, like kind of a burning. So, or probably they can have this kind of a tingling. So this sort of funicular type of a pain can have. These are additional symptoms seen in around 30% of the individuals. Not all will have this. Only 20 to 30% of individuals may have this additional burning, tingling and all in that particular area. Possible they can have a dull funicular type of a pain. But here you might have sometimes, not all the time, sometimes you can have a sharp, like kind of a radicular pain of kind of a thing can be coexisting with the demyelinating disorders. May be possible. Again, in 20 to 30%, you might see some additional abnormal sensations like this also, because the nerves are getting affected and they are crying out of some sort of pain. That's why. So now, as you move on, what about the DTRs? So the DTR loss will be usually multifocal and global sometimes, multifocal and generalized. And that's a very important sign in a demyelinating neuropathy. So a lot of areas will not have the sufficient deep tendon reflexes, because the motor problems are going to be very prominent. Since it's happening in different areas, the reflex loss is extremely important in a demyelinating neuropathy, which we'll be discussing subsequently. But on the other hand, here the DTR loss and as well as the power loss, as I told you previously, it will be limited to the area of sensory loss. Limited to areas of sensory loss. So only, for example, if you have a glove and stocking type of sensory loss, you might be getting the reflex loss only in the ankle. So ankle, and probably sometimes in extensive injuries, the knee jerk may be lost. But apart from that, other reflexes will be normal. For example, if you take a disease like Guillain-Barré syndrome, I mean, you may not be able to see even the triceps reflex, even if only the power loss is confined to the lower limbs. So that's a multifocal and generalized reflex loss, and that's a very, very important sign. So as a nutshell, even though there are considerable overlaps between axonal and demyelinating type of neuropathy, the most important fact as far as axonal is the sensory problem. So that's how the axonal problems are going to come. And the demyelinating is going to be more of a motor problem, reflex loss, atrophy, weakness. So this is going to be the most important problem in demyelinating, even though there is a huge amount of overlap between these two disorders, clinically speaking. but axonal, predominantly sensory problem, demyelinating, predominantly motor problem. Motor problem and demyelinating used to be more often generalized, multifocal reflex loss. A lot of areas will not show reflexes but in the axonal type of neuropathy, it will be limited to the areas of sensory loss. And when you talk about this kind of a glove and stocking type of a neuropathy, you think about an axonal loss because it is more of a length dependent type of neuropathy. But that is the reason why, because it's very difficult to understand what is demyelinating, what is axonal clinically, we have something called a nerve conduction study. That's why we want to do something called nerve conduction study, which can clearly tell whether the patient is having a demyelinating type of neuropathy or a axonal type of neuropathy, or if the patient is having both a demyelinating or axonal type of neuropathy. For example, to understand NCS, because there are some findings which you need to know, which I'll be substantiating in some time, you need to know what is the basis of a nerve conduction study. Let us draw an arm. So this is one of the worst arms you can see, but still let us assume this arm is basically supplied by a nerve. So I can draw this in maybe in red. So this arm is supplied by a nerve. So what we do typically in NCS is we have a recording electrode maybe at this point. So let us understand this is a recording electrode. And let us assume this is the stimulating electrode. Maybe you can keep at this point. So this is a stimulating electrode. And we know very well the moment you stimulate, there is a point of stimulation. It takes some time. So this is not the exact time what you're talking about, but it'll take some time because the impulse has to travel, because nerve have fixed velocity. Even light has a finite velocity. And of course, the nerve conduction also has a finite velocity. So it will take some time. It will not happen immediately. So after some time, there is going to be a response. So you will see something like this. So this is a response that you will see. And this response is what we refer to as a motor action potential. Or in other words, because this is taking a response because of multiple motor units in that particular area, this is also called as a sum of all the motor potential that is happening with respect to that particular area's motor stimulation. So that's also referred to as a CMAP, compound motor action potential. So CMAP stands for compound motor action potential. That's CMAP. So you have two things to note here. One is the CMAP amplitude. So this is what we refer to as a CMAP amplitude. And this CMAP amplitude is directly proportional to two entities. CMAP amplitude is directly proportional to two entities. One is the number of firing axons, number of firing neurons, or number of firing axons. You can call in either way. And at the same time, it's also proportional to the number of motor units that are firing. Because even if there are axons, you need to have that sufficient amount of motor units that are firing. So somebody has to tell me what is the definition of a motor unit. So when you call it as a motor unit, this is a very simple question from the time of physiology itself. What is a motor unit and how a motor unit functions? Any idea? What is a motor unit? Peripheral nerve along with the muscle supplied. Actually speaking, you have to include the anterior hornsel also. To be honest, this is the common mistake that you do in exam whenever you ask about YOC. It's the anterior hornsel, single anterior hornsel that produces a single motor nerve fiber. It's not about a peripheral nerve fiber. We're talking about a motor nerve fiber that's having multiple divisions that are going to supply each and every individual muscle fiber like this. So which means it's an anterior hornsel, it's motor nerve, along with the muscle fibers that they are supplying. So this entire unit is what we refer to as a motor unit. So clear? So one anterior hornsel with the help of one motor nerve fiber, it can supply multiple muscle fibers. So this is a motor unit, and you know very well that depending on the areas, your number of muscle fibers that are supplied may be less or more. For example, in extraocular muscles where you need this precise kind of a movement, or in the fingers. So you have a little bit of lesser number of muscle fibers supplied by single motor unit. So you need more precise movement there. For example, in other areas like shoulders or back or in the thighs, one nerve fiber will be supplying many muscle fibers. So which means the size of the motor unit will be very big. So that's what I'm talking about. But in hands, in extraocular muscles, the size of the motor unit will be very small because it will be supplying only limited number of muscle fibers. So this is the definition of motor unit. So depending on number of motor units that are firing and depending on number of firing neurons are firing, number of axons, so that's going to tell you what is going to be the CMAP amplitude. So the amplitude of contraction. And after that, you know very well what's going to happen. Remember, suppose if you are stimulating a neuron at this point, for example, let us assume you are stimulating an axon at this point and you are recording at this point because you are recording from a particular area which is contributed by multiple motor units. Sorry, this is a stimulating electrode. So in this setting, we know that you are going to get a forward response, that is a CMAP. So once you stimulate, the impulse travels in the forward direction and you get a compound motor action potential. At the same time, this impulse can travel in the reverse direction also, and it can stimulate the anterior horn cell, and this can elicit another response from the anterior horn cell, which can travel forward, and they can produce another response in the motor unit. It will be a very small response. It's a retrograde kind of an issue. So this small response is what we refer to called as a F wave that happens after the compound motor action potential. That is because of the retrograde stimulation of the anterior horn cell, and you're eliciting another response from the anterior horn cell. It's a very small response, but still sometimes it becomes really important. So this is what we refer to as something called a F wave. F wave is important in a lot of scenarios. For example, F wave is produced only when the nerve and the anterior horn cell is intact. For example, if a nerve is completely transected at this point due to a traumatic injury, you cannot get an F wave. So you might get a forward wave still if the nerve is not degenerated yet, because nerve degeneration takes some time. The nerve is not degenerated. Even in a complete transection, you will be able to get a forward kind of a wave, but the F wave will not be produced. So F wave is important to understand about whether the nerve is regenerating or not, whether the nerve is still transected and it's not getting regenerated. So in that way, F wave will be useful. And in the second way where F wave will be useful is to see the intactness of the anterior horn cell. So whenever the anterior horn cell is not intact, you may not get a proper F wave at all. So F wave is to see whether the nerve is intact or not, and to see the intactness of the anterior horn cell as well. In the setting of a traumatic nerve injury, whether the nerve is regenerating or not is what we are going to assess by the visualization of the F wave. Because if the F wave comes back after even complete transection, after 1 week or 2 weeks, if the F wave comes back, we can understand that the nerve is getting regenerated actually. So it indicates a good prognosis. The nerve is getting regenerated. Okay. So these are the things that we need to know. But apart from that, there are a few other things that also has to be noted here. One is the velocity. Remember, we know the distance between this area and this area, and that's something measurable, right? From this area to this area, we know the distance, what is happening. And of course, we know the time also. So there is some time that is taken by the impulse to produce a compound motor action potential. This is the time. So we know the distance between these two areas, and we know the time that is taken to travel as well. So once you know the distance and time, you will be able to tell the velocity also. Velocity, simple formula, distance by time. So that is the velocity. So we'll be knowing the conduction velocities also. So this time is what we refer to as CMAP latency. CMAP latency, because it takes some time for the compound motor action potential to start. So that's what we refer to as a compound motor action potential latency. And of course, based on this latency period and the distance as we know it, we can actually know the velocity of conduction also. So these are the basis, and using this only we are going to construct. So now if you take a demyelinating neuropathy, the most important thing is the velocity. That's what we're going to look for. Because as far as demyelination is concerned, the velocity will be the most important thing that will be affected, because the myelin is important to increase the velocity of conduction within a particular nerve. So which means I can also write that this velocity is directly proportional to the myelin content. The more the myelin is, more will be the velocity. Lesser the myelin is, lesser will be the velocity. Which means I can also derive some relationships based on that. For example, the CMAP latency will be inversely proportional to the velocity, which in turn is directly proportional to the myelination. So latency and myelination are inversely proportional, but velocity and myelination are directly proportional. So velocity increases means the time taken to reach will be less. Velocity is less means the time taken to reach will be more. So I can give a derivation like that also. So the most important thing to look for is the myelination and the, with the demyelinating disease is the velocity and the CMAP latency, both of which will be basically increased. At the same time, there is another latency period also. This is called as an F wave latency over here. After the CMAP, how long it takes for the production of the F wave. First of all, F wave is produced or not is a question, but at the same time, you have to look out for how fast the F wave is produced. And again, this depends on the myelination status. In demyelination, even the F wave latency will be very high because the velocity of conduction is very low. Based on this, we can construct the differences, axonal versus demyelinating neuropathy. So what will be the typical nerve conduction study findings as far as the axonal neuropathy is concerned? Number one, the first is in axonal neuropathy. For example, if there are 100% axons in an area, now you have only 50% of the axons. Half of the axons are destroyed and half of the neurons are not there. In the sense, first thing in a typical axonal neuropathy will be a reduced CMAP amplitude. Reduced CMAP amplitude. So that's going to be the most important point as far as the axonal neuropathy is concerned. But that does not tell you that it's an axonal neuropathy. The patient may have a normal conduction velocity, because even if there are only 50% of axons, if it's a pure axonal neuropathy, you're going to have a normal conduction velocity only. And of course, you will have a normal latencies also, in the sense like velocity is still normal. So the latency, CMAP latency, F wave latency will be perfectly all right. So fine. So this is what is going to be the typical NCS finding in a pure axonal neuropathy. But what will be the findings in a demyelinating neuropathy? So depending on where the demyelination is, they'll be having some two important things, that is called a conduction block and a temporal dispersion, which we'll be talking about that. But more importantly, there will be reduced conduction velocities. That's the most important thing to speak here. And at the same time, there will be increased latencies. So this is easily understandable. But there are two more terminologies that become even more important in the setting of a demyelinating disorder. One is called a focal or a multifocal conduction block. And the second is a temporal dispersion. So this is also very typical of a demyelinating neuropathy. So what do you mean by a conduction block and what do you mean by a temporal dispersion? Let us see. So what do you mean by that? So you have now similarly, you have a nerve that is supplying a motor unit and you're trying to stimulate that particular, it could be median nerve or ulnar nerve, whatever nerve it could be, doesn't matter. So now you have a stimulating electrode and a recording electrode. Let me draw a stimulating electrode here and a recording electrode here. And let us also assume that there is a foci of demyelination here. Foci of demyelination here. And to start with, even though this is not the exact way of description, to start with, let us assume you are stimulating at this point, stimulating the nerve at this point, not at this point, stimulating the nerve at this point. If you're going to stimulate the nerve at that point, this segment is completely normal. So you will have a normal CMAP only. And all the velocities will be normal velocities, normal latencies. So there will be no problem at all because the foci of demyelination is basically at this point. So now let me go to the point number 2. So in the second area, I'm going to stimulate here. So this is number 1, this is second 2. In the second site, if I'm planning to stimulate, now the problems will start. So in the sense like, because this, like stimulation I'm giving has to cross this demyelinated area, and there's a foci of demyelination. Because demyelination will slow down the velocities significantly, of course, you'll be having reduced velocities now, number 1. And at the same time, even the conductions will decrease because there is like a block, because of demyelination, that area of demyelination acts as something like a blocked area. So which means you will have a reduced CMAP also in this, from this, if you stimulate from this particular site. So based on this, you can clearly tell that my foci of demyelination must be somewhere in between the two, because after that, if I do, my velocities and CMAP is normal. And after that, progressively, it is actually getting reduced over a period of time. So which means my foci of demyelination should be between that two areas. Based on that only, we can pinpointly localize where is the exact level of demyelination. And third, let us assume there is another foci of demyelination here. And now if you stimulate at this point, at point number 3, Now this impulse has to cross two blocked areas. It's like keeping like hurdles, isn't it? You have to cross a lot of hurdles to reach the final destination. So now the more the hurdles you reach, the more time you're going to take. So, and the more there is going to be a conduction block. So you're going to result in more reduction of the Cmap and more reduction of the velocity. So that's why depending on the number of demyelinated focus, number of blocked areas, you're going to have sequential and progressive decline in the Cmap and the velocities. This kind of progressive decrease in the Cmap, compound motor action potential, depending on the number of demyelinated areas, is what we typically refer to as something called a conduction block. Conduction blocks, that's typically very classical of a demyelinating lesion. And if you see this kind of sequentially decreasing velocities over a period of time is what we refer to as temporal dispersion. As you move further, depending on the number of demyelinated areas, the blocks and the decline in velocities and decline in increase in the latencies will be more severe. And this is what you mean by a conduction block under temporal dispersion. So whenever you have a focal or a multifocal conduction block and you have a temporal dispersion, this is how a neurologist is going to give the report in the NCS as a demyelinating type of a neuropathy. Sometimes you might have both also. The overall Cmap amplitude will be low. Wherever you do, the overall Cmap amplitude may be decreased. So that is suggestive of axonal neuropathy. But the patients may also show as a whole, because we have a standard, what should be the conducting velocity for a particular nerve. All these things have been researched already, and we have a standard like tool for all these. Even the computer program knows that. So as a whole, your conduction velocity is decreased, your latencies are high, and as a whole, if your Cmap amplitude is also low, wherever you keep. So then in that setting, you'll be diagnosing a combined axonal as well as a demyelinating neuropathy. And in that itself, you can predominantly tell which is the prominent component because, for example, you might have a focal or multifocal conduction block and temporal dispersion together with overall decline in the conduction velocity and increase in the latencies. And along with that, overall as a whole, wherever you keep, the Cmap latency will not be up to the standard for that particular nerve. In that setting also, you can tell there is a mixed demyelinating and axonal type of neuropathy, where the demyelination is the prominent finding, whereas axonal is only a additional finding that the disease causes. So based on that, you can give anything and everything. So you can tell where is the conduction block exactly. Cmap decreased in both axonal and demyelination. I mean, it depends on, because Sankhya is asking whether Cmap is decreased in both axonal and demyelinating. It is your understanding that makes the difference. So if you ask like black or white, Cmap is decreased or not, I will tell yes, of course, because even in a conduction block, even a demyelinating lesion, if you go beyond that demyelinated area and if you test for it, of course, Cmap will be reduced. But if you're asking in a very primitive manner, like at a final year level or a pre-final year level, or maybe like a beginner, you want to answer only NEET PG exam question. In that setting, if you want to answer, so I will answer decreased Cmap amplitude usually goes towards a axonal type of a neuropathy. If you ask black or white, then the answer will become different. So in medicine, it's not always about black or white, it's always about understanding. So there is a lot of gray areas in that. This is not a gray basically, it's a simple understanding. So of course, there is a focused demyelination, and if you keep a stimulating electrode proximally to that, definitely you're going to have a reduced conduction only because that area is typically demyelinated. So you cannot really expect the Cmap to be normal in that setting. So Cmap decrease can happen in both axonal as well as demyelinating. Again, in what context you're answering is really, really important. So that's the most important point to know. And at the same time, in axonal neuropathy, throughout the length of the neuron, throughout the length of that particular nerve, you will have a reduction in the Cmap amplitude. But as far as the demyelination is concerned, it's going to be the blocks. So which means as you move proximally, the Cmap amplitude will decrease further and further. So that's a lot of difference. So if you have a same Cmap amplitude, but grossly decreased throughout the length of the nerve, so that is going more towards an axonal type of neuropathy. If you have kind of a block in between, like as you move proximally, the Cmap is decreasing further. So that's more of a demyelinating type of a neuropathy. So it's all about how you take it. But for NEET PG exams, if you ask reduce Cmap amplitude, I'll go for axonal neuropathy. If you blindly ask me reduce conduction velocity and increase latencies, I'll be going for a demyelinating type of a neuropathy only. Even though so many other factors are also there in this particular NCS, but still this is the maximum that you should be able to know. Clear? Do you understand? I mean, this is the least you have to know, and you don't really need to know much. Got it or not? So Cmap amplitude, velocities, conduction block, temporal dispersion. Yes, so that's very important because whenever you talk about Guillain-Barré syndrome, the first point that they're going to give is something called a conduction block and a temporal dispersion. Don't get really confused. What do you mean by a conduction block and a temporal dispersion? Clear? And more importantly, here something called etiologies. Etiologies also, which we'll be discussing. And more than that, you have another type of neuropathy called entrapment neuropathy. Entrapment. So entrapment is also typically diagnosed based on this conduction block and temporal dispersion only. So what do you mean by entrapment? So for example, in a carpal tunnel syndrome, you know that the main problem is going to be here only. So same principle I can apply here. I mean, you can imagine like that kind of a focus of a conduction block and a temporal dispersion is going to happen at the level of the wrist. So if a neurologist tries to stimulate at this point, you'll have a normal conduction velocities, normal CMAP and all this stuff. But if the neurologist tries to stimulate at this point, just immediately beyond the wrist, proximal to the wrist, suddenly he will get this low CMAP and conduction velocities. So it will be only one point because wherever he keeps proximally to that nerve, after that, he will not have any decline in the velocities, which means you can understand that there is a single focus of conduction block and temporal dispersion that is happening at this point in the wrist. So that is how you can pinpointly diagnose that it's a carpal tunnel syndrome. That's why NCS is very valuable tool in entrapment neuropathies also. The best example is carpal tunnel syndrome. So based on the same conduction block and temporal dispersion principle, I can tell it's a carpal tunnel syndrome as well. Now, next thing is the etiology. So what are the etiologies of peripheral neuropathies? The first thing is axonal type of neuropathy and the second is demyelinating. Again, I can talk about the etiologies here. Let me reduce the size a little bit. Axonal and demyelinating type of a neuropathy. So let us start with a focal kind of a neuropathy. So this is what we refer to as a mononeuropathy. As far as axonal is, demyelinating is concerned, any early entrapment neuropathy will behave like a demyelinating type of neuropathy only. I told you already. So you are going to get a conduction block and a temporal dispersion. This is the best example of a focal mononeuropathy. Single nerve disorder. Early entrapment is the best example where it typically behaves like a demyelinating type of a neuropathy and they are going to produce a conduction block and a temporal dispersion in one particular area. If it's multifocal, then it's diffuse demyelinating type of a disease. If it's only at one focus, typically you think about the entrapment neuropathy. In late cases, because the nerve is severely compressed and for a longer duration of time, late and severe entrapment, now the axons will start getting degenerated. And in that setting, you will be more mimicking an axonal type of neuropathy. That's why I told you there's a lot of overlaps. You have to understand that. Entrapment is example is carpal tunnel syndrome. That's all. Where you'll get only one area, there will be a conduction block and a temporal dispersion. That's all. So that's entrapment neuropathy. So then you have this kind of an acute and multifocal. Acute and chronic. We can divide into acute and chronic. Acute, you can have something called as a multifocal neuropathy. Acute multifocal in the sense like we are talking about a mononeuritis multiplex. Mononeuritis multiplex. Acute multifocal is what we refer to, single nerve disorders is what we refer to as a mononeuritis multiplex. So in this setting, the most important example of a mononeuritis multiplex, we know it's vasculitis. We'll be discussing rheumatology in some time. So that time you'll be knowing more about vasculitis. So I'll be talking more about that. So especially the medium vessel and small vessel vasculitis, especially polyarteritis nodosa, vaginous granulomatosis, Chooks-Strauss syndrome, all these things can produce mononeuritis multiplex. In the world, if they ask you the most common cause of mononeuritis multiplex is going to be vasculitis. What do you mean by mononeuritis multiplex? Multiple single nerves are involved or named nerves. For example, right ulnar, left radial, right ulnar, right radial nerve and left common peroneal nerve, left ulnar, left common peroneal, left median, right common peroneal. So which means many combination of single nerves. If it's involved acutely, that's what we refer to as a mononeuritis multiplex. Typically happens in the setting of a vasculitis. It can happen in other disorders like Lyme's disease. It can happen in other disorders like cryoglobulinemia, which can also produce small vessel vasculitis, of course. It can happen in the setting of a diabetes mellitus also. So these are the causes, but vasculitis still remains the most common cause of mononeuritis multiplex. And as far as demyelination is concerned, multifocal acute demyelination. So what is that? Axonal is mononeuritis multiplex, but we are talking about a multifocal diffuse demyelinating lesion. So where will you get that? In acute setting. You should answer, isn't it? It's a very easy one. We're talking about a demyelinating disease that is multifocal and happening acutely. Of course, yes, it is Guillain-Barré syndrome, GBS. And Linky is answering MS, multiple sclerosis. And I don't know whether Linky has attended the previous session or not, where we have clearly described that MS is a CNS demyelination. It doesn't touch the peripheral nerves. We're talking about a chapter called peripheral neuropathy. And MS, if one thing MS cannot cause, that is peripheral neuropathy. We have discussed multiple times. So the best example is GBS. And one other example you can talk about diphtheria. It causes typically a multifocal acute neuropathy. So as we discussed already, this kind of axonal type of multifocal acute neuropathies is what we refer to as mononeuritis multiplex. And multifocal demyelinating lesion will be seen in GBS and diphtheria. The classic example is Guillain-Barré syndrome. And you can get a polyneuropathy also. So polyneuropathy is not single nerve disorders. It's a kind of a different kind of a disease. So you cannot really tell, like it's a single nerve disease. So nevertheless, so what are the features of, what are the things that cause polyneuropathy as far as that this thing is concerned, axonal is concerned. Mononeuritis multiplex is different. Individual nerves are affected in different areas. Polyneuropathy means it's not going to follow any individual nerve pattern on. It will be like a kind of a different kind of an entity. So yes, axonal, you're going to result in alcohol. Number one, of course, alcohol is very important. Then you have toxins. Variety of other toxins can also produce apart from alcohol. Then you have porphyria, typical example of an axonal type of neuropathy. Yes, correct. Then what else you have? We are talking about an acute lesion, isn't it? We have something called a critical illness polyneuropathy, which happens in the setting of a critical illness, because critical illness can result in polyneuropathy as well as myopathy. Then you can get in certain variants of GBS. These are called as axonal variants of GBS, which can result in polyneuropathy. Axonal variants of GBS, like Aman is there, Asman is there. We'll be discussing in GBS. So that's a variant of GBS. These are axonal variants of GBS. But the classic GBS is referred to as something called AEDP. Again, I'll tell you what is that. Acute inflammatory demyelinating polyneuropathy. But many variants of GBS can cause acute polyneuropathy, like Aman, Asman and all. Fine. So then we are moving on to here. I don't want to tell anything, but then we are moving on to chronic neuropathies. In chronic neuropathies, again, you have multifocal and polyneuropathies are there. Chronic multifocal axonal neuropathies can happen in setting of diabetes mellitus, where in this setting, this becomes the most common cause for chronic multifocal axonal neuropathies. Then we have sarcoidosis, which can cause axonal neuropathy. Then we have HIV. Then we have amyloidosis. Clear not, isn't it? All these things can produce a chronic multifocal neuropathies. And as far as this side is concerned, you can think about leprosy, paraproteinemia, that is multiple myeloma, very important cause in exam, or any condition that increases the monoclonal antibodies. Then you have another disorder called as MMN. This is very important for exam. That's called a multifocal motor neuropathy, which is one of the important differential diagnoses of a motor neuron disease. We have discussed already. So that is called multifocal motor neuropathy. Why it is a very important differential diagnosis for motor neuron diseases? Because this is a peripheral nerve disorder which affects only the motor nerves. It will not affect anything else. So it's typically going to affect only the motor nerves, but it's a peripheral neuropathy. It's not an anterior horn cell disease. So this will also not have any sensory loss, and that will give a very confusing picture with that of that element type of motor neuron disease. That is like, for example, spinal muscular atrophy is there, polio is there. So many differential diagnoses. In that, multifocal motor neuropathy is very, very important differential diagnosis for an element type of a motor neuron disease. I have told you already there, I think. So that's why that's very important there. And at the same time, you have something called HNPP. That's called hereditary neuropathy with pressure pulses. So which means there will be multifocal entrapment here. Yeah, leprosy will have sensory involvement. I'm not telling leprosy will not have sensory involvement. Pranay is asking leprosy will have sensory involvement. But leprosy is typical of demyelination only. And I never told like demyelination will not cause sensory involvement. Demyelination can cause sensory involvement because there is substantial overlap in that. But what is prominent is that is going to be the answer here. So then you have something called a HNPP, that is called a hereditary neuropathy with pressure pulses. That is HNPP, very important question exam. And we have a polyneuropathy again, which can be chronic, axonal as well as demyelinating. Chronically, once again, alcohol can cause this, of course, very important cause. Then more importantly, you have B12 deficiency, that's very important. I have told there itself in B12 deficiency, where B12 deficiency can produce demyelination in the spinal cord, but it produces an axonal type of peripheral neuropathy only. Very important point, because many students, whenever they think about B12, they immediately think about SACD and they will think it's a demyelinating disease. No, in the periphery, B12 deficiency typically causes only axonal type of neuropathy. But in the spinal cord, they produce something called a demyelination. Then we have something called a Charcot-Marie-Tooth disease type 2. This is one of the hereditary forms of neuropathy, peripheral neuropathy. That's Charcot-Marie-Tooth disease type 2, which is going to be of axonal type only. Then we have IgG paraproteinemia. Usually paraprotein disorders will result in axonal type of neuropathy only, but except this kind of IgG type of paraproteinemias, usually they can produce your axonal type of neuropathy also. Then amyloidosis, chronically they can produce axonal type of neuropathy. Then many drugs, for example, even amiodarone can produce this kind of chronic amiodarone there. Okay, fine. Amiodarone you have to write there, not here. Amyloidosis, amiodarone there, sorry. Then we have multiple metabolic and endocrine disorders typically tend to produce axonal type of neuropathy. But among this, the hero is going to the B12 deficiency. That's the most important. As far as the demyelinating is concerned, I can write CADP. CADP is a chronic polyneuropathy. It's a chronic form of GBS. You can think like that. So chronic inflammatory demyelinating polyneuropathy. Then lymphomas can produce this kind of a picture. Then CMTD type 1, the Charcot-Marie-Tooth, this is type 1, is going to be demyelinating only. And you have IgM paraproteinemias. In the long run, they are going to produce demyelinating neuropathy only. Then we have amyloidosis, means we can remember an associated entity called amiodarone. That's how I remember amiodarone. Then finally, you have arsenic poisoning. Chronic arsenic poisoning will produce demyelinating type of neuropathy. So that's why I told you opposite, like like CMTD1 here, CMTD2 here, IgG paraproteinemia here, IgM paraproteinemia here. So it's very easy to compare now. Amyloidosis here, amiodarone here. So it's very easy to understand. The most important, if you want to know, because there are multiple causes I've told you, this still is very small in terms of a list, what we are talking about. Still you have so much of cause of peripheral neuropathy. That kind of a deep dive is not really important, to be honest. But nevertheless, there are a few questions that they will be asking. One is entrapment neuropathy typically behaves like a demyelination, at least in the early stage. That's one question. Second is they will ask about mononeuritis multiplex, the most important cause that's going to be vasculitis. And acute multifocal demyelinating neuropathy, the most common cause is Guillain-Barré syndrome. The most closest to differential diagnosis is diphtheria. And of course, as far as axonal neuropathies are concerned, the alcohol is very important. Porphyria is very important. Critical illness neuropathy is very important. B12 deficiency is very important. CMTD type 2 is very important. Amyloidosis is very, very important. So these are the 6 causes that you need to know as far as the axonal neuropathy is concerned. And as far as the demyelinating neuropathy is concerned, you need to know about amiodarone, arsenic, CMTD type 1, then multifocal motor neuropathy, and HNPP, that is hereditary neuropathy with pressure pulses. And of course, GBS everyone knows, so there is no point in telling GBS again and again. So these are the 6 causes which I've told you on the right side. That is for the peripheral neuropathy. So if you know this much number of causes, I think that must be enough for exams. Whatever the questions that they've asked in peripheral neuropathy and whatever you need to know for the exams, this much must be enough. I don't think, I mean, if you want to have a PG level discussion, then I can tell what is a predominantly sensory type, what is a predominantly motor type, what is a predominantly autonomic type, what is a mixed type. So they'll be going in such a kind of a discussion if you're dealing with a case discussion kind of a scenario in exam. But apart from that, I don't really think more than this you need. If you really want to show off and you have a PG level discussion, then you can start knowing that also. What is predominantly motor, predominantly sensory, predominantly autonomic? There's a separate courses are there. There are 5-6 courses which you need to know under each. You can go and learn later also, not a problem. If you want to have a case discussion or a PG level discussion, maybe if there is MMS 2.0, I'll be discussing about all those things there, but not now, because that's not really going to give any kind of high yield information for your exam. Then we have Guillain-Barré syndrome, GBS, of course. Guillain-Barré syndrome. As far as GBS is concerned, we know it is the most common type of peripheral neuropathy that is happening of all. I mean, this is the most common type of demyelinating peripheral neuropathy. Demyelinating type of peripheral neuropathy. Many students will get still carried away by thinking that if you know all these things, then peripheral neuropathy's etiology is easy to understand. No, there is a separate textbook by Nielsen is there. So that's a separate textbook on, it's a very old textbook. It's a 90s textbook, I guess. They have not updated it, second or third edition, but it's a very beautiful book which I've read. So for peripheral neuropathy, this is 540 page book. So where they would have mentioned at the end of the book, they would have mentioned, that's a very depressing statement. They will tell like, even after comprehensive etiological analysis and nerve conduction studies and EMGs and all this stuff, still 30% of the neuropathies will still be idiopathic, in the sense like they cannot be able to identify it by any modern techniques or whatever techniques we have. So that's a very depressing statement, isn't it? So much of etiologies you will be knowing after studying that book, and so much of nerve conduction study principles, everything you'll know. But still in 30% of the patients, you might not be able to understand what's really going on. And there will be some evidence of peripheral neuropathy in them. So which means 1 in 3 patients, you cannot really differentiate what's the reason for the peripheral neuropathy, even with extensive investigations. But even though many modern investigations have come, for example, if you think NCS is sensitive enough, you are absolutely wrong, because NCS will be absolutely insensitive to one type of neuropathy called a small fiber neuropathy. So this also tells you that NCS only samples the large fibers. NCS is not going to sample the small fibers at all. So NCS will be sensitive if you are thinking about a large fiber neuropathy, but if it's typically involving only the small fibers, there is no involvement of large fibers at all. That's called as a small fiber neuropathy, which will be typically presenting kind of an axonal kind of a fashion only, but NCS will not yield any information if no large fibers are involved. So NCS will be absolutely normal. In exam, one thing they will be asking you very commonly is the best example of isolated small fiber neuropathy is Sjogren syndrome, which we'll be discussing after some time in rheumatology. So where to find out this small fiber neuropathy, the only way is to do a biopsy from the area where the patient complains of sensory loss. So maximal sensory loss should be tested. And from that area, you will take a biopsy, skin biopsy. And you know very well, the smallest of all the fibers is C fibers only, which means only the C fibers will be lost in that particular area. And that's why in the biopsy, what I'm going to look for is something called a C fiber density. And you have variable cutoffs for that. If the C fiber density is low, then in that setting, I'll be calling it as a isolated small fiber neuropathy, where the nerve conduction study can be completely normal. There won't be any problem in the nerve conduction studies at all. So there are a lot of pitfalls are there still as far as nerve conduction study is concerned, and newer investigations are keeping on evolving over a period of time. But still, we are not able to identify at least 20 to 30% of the neuropathies that are existing in clinical practice. It is still deemed idiopathic only. Anyways, as far as GBS is concerned, very, very important topic for your exam compared to whatever we have discussed till now. GBS is going to be the crown of all those things. So please understand carefully, though it's the most common demyelinating peripheral neuropathy. And remember, you have many different types of GBS. For example, you have a classic form of GBS. That is what we refer to as something called the AADP, that is acute inflammatory demyelinating polyneuropathy. The numbers are variable, but still more than 90% of the GBS will be classic forms of GBS only. That is acute inflammatory demyelinating polyradiculoneuropathy. So that's the definition. And that's the expansion of AADP. Then you have some variants of GBS also. So many variants are there. For example, you have a AMAN, that's called acute motor axonal neuropathy. These are axonal variants of GBS. You have something called ASMAN, that is acute sensory motor axonal neuropathy. And you have something called pan dysautonomic variant. Pan dysautonomic variant. And finally, you have something called a Miller-Fisher variant also. You have Miller-Fisher variant as well. So these are basically the variants of Guillain-Barré syndrome to start with. And more importantly, these variants will have more of a sensory loss. So that's why you should not confuse with this. So remember, in classic GBS, it's always motor only. Motor loss is the prominent entity. But in variants of GBS, you will still have motor loss, which is characteristic of GBS, but still you will have some kind of sensory loss. And pan-dysautonomic variant, it will be more of a bladder bowel involvement. And Miller-Fisher variant will more of a ophthalmoplegia, which we'll be discussing after some time. So in variants, you'll have different entities, but still the pathophysiologies are almost the same. That's why we put everything under similar entity. So classic GBS and variants of GBS, two types are there. As far as the classic GBS is concerned, 60% of the times, it will be due to some sort of viral infection. Some viral infection is the one that is going to trigger this GBS, and it's been concretely proven. For example, you have cytomegalovirus, you have Epstein-Barr virus, which can produce. You can result in GBS because of HIV virus, and a lot of bacterial infections also have been implicated. In that you have the mycoplasma and gastrointestinal infection, mycoplasma and GA infection. And this GA infection most often is thought to be due to Campylobacter jejuni. And in exam, whenever they ask you the organism that is associated with GBS, I mean, it's a common thing to answer a Campylobacter jejuni. That's really important because the examiner expects that only. Even though old textbooks and some microbiology textbooks give Campylobacter jejuni is the most common organism that is associated with Guillain-Barré syndrome, but nevertheless, currently that trend is changing, and there are many organisms that are known to be associated with Guillain-Barré syndrome. And even Lyme's disease has been associated with development of Guillain-Barré syndrome. And immunization, vaccination. So I can tell in viral, right? Vaccination, most of the times you do with for a viral infection only. In fact, vaccination can be done for bacterial infection also, but it's predominantly to cover up the viral infection only. So that's why I'm writing vaccination there. After vaccination also, you might develop Guillain-Barré syndrome. And the Russian vaccine, COVID vaccine that we saw, it didn't only produce acute transverse myelitis, it also caused a few events of Guillain-Barré syndrome also. That's why it was scrapped right now. It's not used anymore. So vaccination can result in development of GBS. That's called a post-vaccination GBS. And you get with Zika virus. This was asked in AIMS 2017, I think, because that time Zika virus was spoken very popularly. I don't think nowadays they're going to talk about Zika virus anyways. Everything is all about COVID only. But in 2017, this created a little bit of like headlines because Zika virus caused that kind of microcephaly in children. If it affecting the pregnant mothers, and it caused a little bit of GBS also. That's why Zika virus was a little bit talked about in 2017 or 2018. Apart from that, I don't think right now you will get any question on Zika virus. So 60% usually it will be due to some sort of viral infection only. So let us see the AADP in detail. So variants I'm not going to discuss in detail. So let us see the AADP in detail. So as far as the clinical features are concerned, you can explain GBS in 4 different entities. So how can you, how can you explain in one particular sentence? So it's an acute, ascending, atoxic, flaccid, quadriparesis. So this is how typically you explain a Guillain-Barré syndrome: acute, ascending, airflexic, flaccid, quadriparesis. You know what you mean by acute? Everything you can start answering now. Acute means there is quite a few definitions for what is acute. So if you take the illness basically in GBS, so usually it will take some time and it will reach a peak. It will be, I'm telling the definition of acute. It will reach a plateau and then it will come back to the baseline level after some time. Remember, if it's a GBS, if the diagnosis of your disease that you're dealing with is Guillain-Barré syndrome, it will come back to the baseline nevertheless. The sense like it will anyway resolve over a period of time if it is GBS. And the time to resolve is going to be approximately around 8 weeks. That's a very important point. Anything beyond 8 weeks, we cannot call it as a Guillain-Barré syndrome. And it will be called as something called a CADP, that is called chronic inflammatory demyelinating polyneuropathy. Only if it resolves within 8 weeks, we'll be calling it as a acute inflammatory demyelinating polyneuropathy. It should resolve within 8 weeks. Okay, whether you treat or not, this is what is going to be the course of the disease. And remember, it's going to reach a peak nevertheless and this peak should be reached within 4 weeks. So what does that mean? That peak is reached within 4 weeks, which means there should not be any disease progression beyond that 4 weeks. In the sense, the disease should become static at least by 4 weeks. And if it is keeping on progressing, worsening beyond 4 weeks, and once again, it's unlikely to be a Guillain-Barré syndrome in that perspective. So it should reach a peak and it should remain static, or it should not progress beyond 4 weeks, and it will reach the baseline and it should resolve within 8 weeks. If that doesn't happen, if it's progressing beyond 4 weeks, then you should highly question the diagnosis of AADP. And if it is not resolving within 8 weeks, then again you have to highly question the diagnosis of GBS. And in that setting, if it's a clear-cut demyelination progressing beyond 4 weeks and happening beyond 8 weeks also, if it is still there, then I can diagnose something called a chronic inflammatory demyelinating polyneuropathy also. This is what we define as something called acute. There is a definition for acute also. Ascending is something very easy to understand, because ascending means initially the weakness will start in the lower limbs, then it will go to the upper limbs, then slowly it starts involving the trunk, then it starts involving the bulbar musculature, then slowly it starts involving the diaphragm, resulting in respiratory failure and death. Respiratory failure in the sense, this is a classic example of a type 2 respiratory failure where you are going to have a normal A gradient, and finally they're going to result in death. So somebody asks you what is the most common cause of death in Guillain-Barré syndrome, I'll be typically answering it's as a respiratory failure. Respiratory failure is the most common cause of death in GBS, and that's why we are worrying about it. So whether you treat or not, the patient anyway is going to resolve if it's a GBS, if it's an acute inflammatory demyelinating polyneuropathy. But the problem is, once they reach the peak stage, there is a lot of chance that they might die because of respiratory failure. That's why we wanted to prevent respiratory failure, number one, or we want to treat the patient in respiratory failure. At the same time, we don't want this peak to happen. Either we want to stop the peak at a lower limit itself, which means it will not go to the level of respiratory failure. Our second thing is we wanted to slow down the progression of the disease so that you can resolve the disease much faster, so that you can reduce the hospital stay. So that is the idea of treatment. The idea of treatment is not to completely halt the disease. So that's not possible. Anyway, even with treatment or without treatment, you are going to resolve nevertheless. But the problem is, during the peak stage, you will die. So if the patient has died, how can they, I mean, the resolution doesn't matter from that point. So you have to prevent death. You have to reduce the severity. At the same time, you have to reduce the duration of illness. So this is the idea of treatment, what you're going to use, which will be discussed later on. And more importantly, most of these patients will have this kind of areflexia. That is because this is a demyelinating disease, typically going to affect the larger fibers, 1A, 1B, or alpha motor neurons. All these fibers will be gone. So typically the patient will be completely areflexic. In fact, even if the patient is having only lower limb weakness, they will not be having reflexes in the upper limb also, because of multifocal demyelination in multiple areas in the body. So areflex is one classical feature of Guillain-Barré syndrome, which means the motor issues will be very, very prominent compared to that of the sensory problems. And as far as flaccidity is concerned, it's very easy to understand, because it's a peripheral neuropathy, lower motor neuron disease. So it's going to be a flaccid kind of a paralysis. And of course, once it starts involving the upper limb also, it's going to cause quadriparesis. So this is a classic, explanation of how you answer a GBS in exam: acute ascending areflexic flaccid quadriparesis. And some people will have sensory symptoms, and this has been described because you know that this is a kind of large fiber neuropathy. So sometimes the neurons might cry out of pain, so they can get some kind of subjective sensory symptoms. But remember, this is only subjective sensory symptoms. Most common subjective sensory symptom will be back pain. And in exam, this is a very important point once again. Many of the individuals may have back pain, and then they have this kind of paresthesias, numbness, and tingling sensation, and they can kind of get a girdle kind of a sensation, girdle-like sensation. That's very typical of a large fiber involvement. So radicular pain. So these kind of subjective sensory symptoms will be there, but usually when you test them, there will be no objective sensory loss, which means patient will be able to still feel the sensations, but still there will be no objective sensory loss, but they will tell a lot of subjective sensory symptoms. Of course, the most important symptom in exam is going to be the back pain. Very common question in exam. A patient who had a recent diarrhea developing. Any specific reason for ascending paralysis? No, actually. People do call it as length dependent, but as far as your demyelinating neuropathy is concerned, like we don't really call it as length dependent. And there are multiple reasons that have been showed for ascending paralysis, but none of them is correct and none of them has been proved or disproved. But nevertheless, this is not a length dependent neuropathy. Even though, some areas in the textbooks, you might encounter the word length dependent in GBS also. But as I have researched in a lot of textbooks like Adam and Victor, nobody really tells that this is a length dependent neuropathy, which is a very classic hallmark of a axonal type of neuropathy. In a pure demyelination, it should not be length dependent. It's an ascending type of paralysis only. Even diphtheria is going to be ascending type only. That's why one of the closest differential diagnosis for GBS, infectious differential diagnosis, diphtheria. Diphtheria can cause ascending type of paralysis only. However, so now we have talked about this kind of infection, isn't it? So usually in exam, what you're going to get is a patient who had a history of probable upper respiratory tract infection, URI. This is some virus only, or they might have a diarrhea. As I told you, this is seen in almost 2/3 of the patients. That is 60% of the patients will have this kind of history. Something will be there in the exam for sure. Then followed by weakness within 1 week or 2 weeks, so they develop weakness. So this is very characteristic feature of a Guillain-Barré syndrome. This is how you diagnose a Guillain-Barré syndrome in the first place. And especially this diarrhea is important because diarrhea history may be due to Campylobacter jejuni or may not be due to Campylobacter jejuni, will be usually associated with a more severe disease. I'm not telling poor prognosis, but will be associated with a severe disease. That's the point that you have to know. Diarrhea history as a prodrome will be associated with a severe disease. Remember, 1/3 of the patients may still not tell any history of URI or diarrhea, but still if they have history of URI or diarrhea, if the diarrhea is there, then it indicates usually a severe disease. That's also one question in exam. And at the same time, Shubham is asking whether variants of GBS will have association with organisms or not. Of course, yes, we are talking about a GBS as a whole, even variants of GBS. And many of the Aman cases typically are with Campylobacter jejuni. Again, many of the variants of GBS also have been known to get associated with infectious organisms. Clear? No objective sensory loss. Fine. But the patient, we are talking about a classic GBS now, AADB. The patient may tell many subjective sensory symptoms, but usually they might not be having any objective sensory loss. And autonomic failure can happen, and autonomic instability can happen in the setting of GBS, and they can develop even arrhythmias to some extent, which can happen in almost 60% of the individuals. Arrhythmias can happen in 60% of individuals. You should watch for them also. Even though it's a demyelinating lesion, autonomic fibers may be null because there is always an overlap between demyelination and axonal type of neuropathy. Usually the problem with the students is they see demyelination means only demyelination, axonal means axonal. So whenever the nerve is severely damaged by demyelination, the axons also may go for degeneration because there is a damage to the axon as well. You can never separate. It's like separating your sensation and skin. So sensory loss is separate, skin is separate. It's like separating them. Never separate axonal and demyelinating as far as clinical practice is concerned. So only for basic level understanding, for physiology level understanding, we separate axonal demyelinating, but majority of the times, everything will be interrelated and connected with each other only. So how can you separate a myelin and an axon separately? So that's ridiculous, isn't it? That's how I tell the students whenever they ask, like, sir, you told this in axonal, you told this in demyelinating. So I cannot really see a myelin and axon separately. So that's not possible. Whenever myelin is damaged, there might be some axonal damage. Whenever axon is damaged, there can be some myelin damage. Both are closely pinned with each other. How can you separate them? Not possible. So that's why, I mean, when you understand this, it becomes simple. Once you don't understand this, if you think like axonal separate, demyelination separate, both should not be mixed with each other, then it becomes really complicated and you will keep scratching your head forever. Okay. So this is how a GBS is going to present nevertheless. And what are the investigations that you can do? There are some investigations that you can do in the setting of a Guillain-Barré syndrome. What investigations you can do basically? There are two investigations. One, of course, is going to be the nerve conduction study. Typical finding in nerve conduction study, you know, is going to show demyelinating pattern, that is that multifocal conduction block and temporal dispersion. That's what is going to be there. And second is the CSF analysis, which you can do, where you see something called albuminocytological dissociation. That's a very common question in exam. And even a final year student knows this, isn't it? That's called an albuminocytological dissociation. So what do you mean by albuminocytological dissociation? So usually in the CSF, whenever there is increased proteins, there will be increased cells also. And this is a usual entity. I mean, if you take an infection or anything, the number of cells will be increased and number of proteins also, amount of protein also will be increased. This relationship is the one that's going to suffer in the setting of a Guillain-Barré syndrome, because in a Guillain-Barré syndrome, there will be increase in proteins only, but the patients will have normal cells. So this kind of dissociation is what we refer to as a albuminocytological dissociation. And that's one of the things that we are going to typically look out in the setting of a Guillain-Barré syndrome. So you have multiple differential diagnoses for albuminocytological dissociation, but as far as exams are concerned, whenever they give albuminocytological dissociation, it means it's a AADP or a CADP, that is polyradiculopathy. So it's acute or chronic. So, but in the setting of an acute weakness, so we are typically going to diagnose GBS only. In exams, this word albuminocytological dissociation, increased protein with normal cells, is equal to GBS only. Typically, remember, normal cells means the number of cells should be less than 5 in the setting of a Guillain-Barré syndrome. Up to 50 is acceptable. If, for example, a patient with HIV is there, for example, in HIV patient getting a GBS, up to 50 is acceptable to in some extent, in some disorders. But anything more than 50 is unlikely to be a Guillain-Barré syndrome. It typically rules out a Guillain-Barré syndrome. Remember, this number of 50 is very important in 2 areas. One is in multiple sclerosis. Remember, multiple sclerosis also, you will see slightly increased cells, but you will never see more than 50 cells in MS, multiple sclerosis. Even in GBS, maximum number of cells you can see in 50, that too in selected conditions, but classical scenario is seeing a normal cell, that is less than 5. But up to 50 is acceptable in certain situations. But beyond 50, unlikely to be multiple sclerosis also, unlikely to be Guillain-Barré syndrome also. Even though both disorders are completely different disorders, one affecting the central nervous system white matter, one affecting the peripheral nervous system white matter. But nevertheless, it's 50 cells, that's the standard. Beyond that, you cannot see. More than 50, unlikely to be MS or unlikely to be GBS. In the CNS, more than 50 usually goes towards an NMO, neuromyelitis optica. We discussed already. Here, if it is more than 50, it is something else. Like even CADP can present like more than 50. That's different. We'll discuss about that later on. But in GBS, AADP, you cannot see more than 50. That's important. Okay. And remember, these investigations may take up to 1 week to become abnormal, which means you might not get all these abnormalities immediately. It might take up to 1 week to get these changes in the investigation. So which means do not wait for the investigations. That's a very important point. So you have to start the treatment even before the investigations have come. At the primary level of suspicion itself, you have to start. Otherwise, you will lose the patient. So what is the point in treating a dead patient and finding out the diagnosis in them? There's no point. So start treatment as soon as possible. The moment you suspect GBS, you can start empirical treatment. No problem. No need to wait for the investigations. You can do later on also. So as far as the investigations are concerned, you need to think about the respiratory failure, whether respiratory failure is there or not in the first place. If it is there, first priority is to save the life of the patient. You are going to intubate these patients first, and then you are going to give a definitive treatment. Suppose if the patient is not having a respiratory failure, then you can proceed towards the definitive treatment. So what is the definitive treatment? Of course, it's going to be IVIG. That's the first line treatment. Or alternatively, you can go for plasma exchange. So remember, IVIG and plasma exchange should not be added. So which means I can write they are not additive with each other, which means any one only you should follow and do not add. They are not additive, which means their effects are not going to be additive in nature. Only one you are going to add at any point. So either IVIG or plasma exchange, either intravenous immunoglobulin or plasma exchange, and it's not going to be additive at all in the first place. Clear? So this is going to be the definitive treatment as far as the Guillain-Barré syndrome is concerned. But more important point is the steroids are not beneficial. So you're not going to use steroids in AADP, and there are a lot of trials that have been done on steroids, but typically, and there are a lot of reasons are there why steroids are not effective, but again, speculations only. And again, knowing that you're not going to achieve anything in life, first thing that you need to know is steroids are not beneficial. Multiple times asked question. All of the following are used in treatment of GBS except steroids. Very simple, not useful in AADP. But in the setting of a CADP, steroids may be useful. That's different because that's an ongoing inflammation. So steroids may be useful in the setting of a CADP, but definitely not in AADP. Clear. So how much IVIG will give? Typically, IVIG's dose is very important. Usually, will give 2 grams per kilogram in any setting. Even Kawasaki disease, this is the same amount of IVIG that you're going to use. 2 grams per kilogram is the standard, and it should be given over 5 days. Given over 5 days. In our hospital, there is a general practice. We'll give 1 gram per kilogram first day, and second day we'll give another 1 gram per kilogram. But there are some traditional dosings also, like 0.4 gram per kilogram that is given for 5 days. So when you give a 0.4 gram per kilogram for 5 days, it reaches 2 gram per kilogram net dose. The total dose should be 2 gram per kilogram nevertheless. But in our hospital, we don't give 0.4 gram per kilogram. We tend to give 1 gram per kilogram. Just we repeat 2 days. First day and second day 1 and day 2, that's enough. If you want to repeat, you can repeat. If you have a good response and not a full response, still you can repeat the IVIG, not a problem, but not in the guidelines. But more importantly, don't use IVIG and plasma exchange together. They're only going to increase the cost without any much benefit. Plasma exchange also you can do. We can give 2 to 3 settings. And again, how much plasma exchange to do is beyond the scope of the current discussion. But in our hospital, we prefer using IVIG over plasma exchange because plasma exchange is more invasive. At the same time, you need a central line to be inserted, and risk of infection is a little high, and the cost of therapy is also a little high, and patients' morbidity is also a little high as far as we know. With plasma exchange, as far as the efficacy is concerned, if you're in a very resource-rich setting, then both should not be a problem. Either IVIG or plasma exchange, both has almost similar kind of an efficacy only. So efficacy-wise, there is no difference between them. But don't use steroids. That's the idea. So then we have some variants of Guillain-Barré syndrome. How do you know about variants of Guillain-Barré syndrome as far as AMA and ASMA are concerned? These are basically axonal variants. So you might have some kind of a sensory loss may be there. Some kind of sensory loss may be there. But still the motor weakness will be the prominent because it's GBS. But still you might get some amount of sensory loss. Sankhya is asking any association with facial palsy with GBS. I told you already, when you get a bulbar palsy means you can get any cranial nerve involvement. Plus or minus, any cranial nerve involvement can be there. But as I told you, 1 and 2 will not be involved because they are not peripheral nerve structures. We have discussed that already in detail. I thought you will be getting. And the most common cranial nerve involved in Guillain-Barré syndrome is 7th cranial nerve. And usually it will be bilateral than unilateral, which means bilateral cranial nerve palsy is 7th nerve palsy is more common compared to that of unilateral 7th cranial nerve palsy. And of course, we know it's an element type of palsy because it's a peripheral neuropathy. Very common. And if they ask you what is the most common nerve that is involved in GBS, cranial nerve, that is 7th cranial nerve. And of course, bulbar will involve a little late. And whenever the bulbar palsy is there, the next is diaphragm only. That's why bulbar palsy is a very serious sign in neurology. I mean, in fact, like any no neurologist will take bulbar palsy very easily. Because once you get bulbar palsy, if it's going to peripheral neuropathy, then of course, within short span of time, the patient will go for respiratory failure and they will die. That's why bulbar palsy is a very important sign. But nevertheless, most common nerve, cranial nerve that is affected in GBS is 7th cranial nerve only. But let us move on to this AMA and ASMA. They might have a little bit of sensory loss. So which means, sensory loss, sensory symptoms, all these things can be there in AMA and ASMA. So they are axonal variants. That's quite understandable. And at the same time, there are some strong association of AMAN with Campylobacter jejuni. Even others can be associated, but AMAN has a little bit of stronger association with Campylobacter jejuni. Number one, that point you need to know. At the same time, there are some antibodies that are associated with AMAN. That is anti-GM1 antibody, which is strongly related to Campylobacter jejuni again. And these are the antibodies that are associated with AMAN. The classic GBS, I don't really think that antibodies are associated. But with AMAN, anti-GM1 antibodies associated. Then we have anti-GD1A. These are ganglioside antibodies that is associated with AMAN as well. And these are two antibodies that you need to know. Anti-GM1 and anti-GD1A. Both are ganglioside antibodies, but anti-GM1 is a multiple times asked question. Very commonly asked in NIMHANS exams, very NIMHANS favorite. Anti-GM1 antibody. Association with AMAN. And AMAN in turn is associated with Campylobacter jejuni. So you can also tell that anti-GM1 antibody is very strongly correlated with Campylobacter jejuni infection. I don't think you need to know anything beyond this. And one more thing they will be asking you is this Miller-Fisher variant. Very common question in exam. Miller-Fisher variant is associated with something called an anti-GQ1B antibody. So that's a very important question again. Not asked yet, but I believe that this question will be surely asked. Anti-GQ1B antibody, that's with Miller-Fisher variant of GBS. And as far as Miller-Fisher variant is concerned, it's basically a triad. We know what is a triad. It is ataxia, areflexia, and ophthalmoplegia. Areflexia and ophthalmoplegia. So this is classic Miller-Fisher syndrome. Miller-Fisher syndrome. And the most common cranial nerve that is involved in this ophthalmoplegia is cranial number 6, then followed by cranial number 3. So 6 is very commonly involved, then followed by 3. Very classic Miller-Fisher syndrome, ataxia, areflexia, and ophthalmoplegia associated with anti-GQ1B antibody. Treatment remains the same. It's like GBS only. Plus, if you have encephalitis, patient is also having associated encephalitis, especially if it is happening in the brainstem. And you can see this in MRI. Typically in GBS, MRI brain will be normal and they will not have any, encephalitis features. But if you really have associated brainstem encephalitis, along with this classic triad, ataxia, areflexia, and ophthalmoplegia, that is called as a Bickerstaff brainstem encephalitis. I can write as BBE, Bickerstaff brainstem encephalitis. That's a BBE. And at the same time, you need to know that this Bickerstaff brainstem encephalitis is also associated with anti-GQ1B antibody. So, I mean, now we can be very clear that it's the disease association with antibody, and it's the antibody that is causing the disease. So that is the correct statement. So antibody, that is GQ1, anti-GQ1B, can produce both Miller-Fisher as well as Bickerstaff brainstem encephalitis. A relatively more severe variant with encephalitis is Bickerstaff brainstem encephalitis. Relatively milder variant is going to be the Miller-Fisher syndrome. But nevertheless, even Bickerstaff brainstem encephalitis almost has a very similar treatment to that of GBS only. But you can understand, like in exam, one more triad that will be commonly confusing you is this triad. So if I just remove this areflexia, and if I put ataxia, ophthalmoplegia, and just I am going to remove the areflexia part, and in exam, if they give confusion instead of this areflexia, what is going to be the triad? What is the answer here? This is very simple, isn't it? What is this triad? If you have ataxia, confusion, ophthalmoplegia, instead of areflexia, I have just removed one part of the triad and I have replaced with another entity. This is somebody selling Wernicke-Korsakoff syndrome. No, Korsakoff is different. We are talking about Wernicke's encephalopathy here. This is a Wernicke's encephalopathy. I mean, in exams, this becomes important because you will confuse with that Miller-Fisher triad. So here the confusion is the key. And usually this confusion is most of a global confusion, not to particular domain. So that's why it's called a global confusion. Ophthalmoplegia and ataxia. So usually it will be given by a mnemonic called COAT. You know that. C stands for confusion, O stands for ophthalmoplegia, and A stands for ataxia. And the final T, it stands for thiamine as a disease, or you can remember it's the pathophysiology and it's the treatment also. So you can imagine anyway, treatment is thiamine. So I generally believe that T stands for treatment is thiamine. Treatment is thiamine, so that's going to be the most important. Even thiamine deficiency is going to be the reason for development of Wernicke's encephalopathy. Everyone knows the most common reason for development of Wernicke's encephalopathy is going to be alcohol only. I'm not denying that fact. Quintessentially more important point, alcohol. But there are many other causes also. Thiamine deficiency can happen in the setting of hyperemesis gravidarum. Usually why I'm telling this point is because this is an exam favorite. Everyone knows that when you take alcohol, you're going to develop Wernicke's. So no fun in asking that. But they generally tend to ask this hyperemesis gravidarum only. That's a very important exam point because a pregnant mother who's vomiting continuously develops sudden ataxia and confusion. Think about Wernicke's in that setting, and you have to start with empirical thiamine. So that's one point that could be asked in exams. And at the same time, even malignancies, even though it's not a very important point in exam, you need to know malignancies can cause cachexia, and because of that poor nutritional intake and consumption by the cancer cells, they can develop thiamine deficiency and subsequent Wernicke's encephalopathy, which should be kept in mind as well. But more important for exams is going to be the hyperemesis rather than the alcohol. We know alcohol, that's why. And Korsakoff psychosis is an amnestic variant. That's completely different. I don't know whether to tell or not. It's more of a psychiatric disorder. I mean, more than psychiatric disorder, that's amnestic syndrome. We don't call it as Korsakoff psychosis anymore. we call it as a Korsakoff amnestic syndrome. That's called a KAS because it's no longer a psychiatric disorder. It's just a form of an amnesia where the patient will typically have something called a confabulation. And if you do investigations, the most important investigation that we do is MRI and erythrocyte, RBC transcranial also can be done. Do we clinically diagnose confusion? No, it's not a clinical diagnosis of confusion. How can you diagnose confusion clinically? It's just the cognitive domains that are dysfunctional. So that is what we call it as a confusion. In the sense, confusion has a lot of objective scaling also. Like for example, you have something called a mental test score. MTS is there. And you have mini mental test score. MMTS is there. And you have a Colorado test score is there. CTS is there. There are so many test scores that can diagnose confusion. But nevertheless, any condition that produces sudden change in the cognitive functions is what we typically call it as a confusion. Not only the memory, any cognitive area, if it's suddenly dysfunctional, it's becoming dysfunctional, we call it as confusion. And even though you have test scores, in common practice, it's not about the test scores. It's about the, second to second evaluation of the cognitive function. So sudden change, confusion. That's the basic idea. And what about MRI? Investigation is going to be the MRI. In MRI, what are you going to see? Typically, you're going to find changes in two areas. One is going to be in the mammillary body. And second is going to be in the thalamus. In the thalamus, typically, you will see in the dorsal nucleus, that is called DTN, dorsal thalamic nucleus. So these are the two areas where you're going to see. And these can show necrosis. That's called mammillary body necrosis or a necrosis of the dorsal thalamic nucleus. So even though necrosis of the thalamus indicates high severity, necrosis of mammillary body is something we see very commonly in T2 weighted MRI, but thalamus having changes is indicative of higher severity of the disease. But nevertheless, MRI means mammillary body as far as Wernicke's is concerned. And this disease can have an associated Korsakoff amnestic syndrome also. Remember, Wernicke's is completely reversible. Wernicke's is completely reversible with time and treatment. And if they ask which is the first thing to resolve with time and treatment, my answer will be ophthalmoplegia. This is the first thing to resolve with time and treatment. And the second thing to resolve is going to be the ataxia. And the final thing to resolve will be the confusion. Last to resolve is the confusion. First to resolve is ophthalmoplegia. Next is ataxia. And the final thing to resolve is the confusion that happens in Wernicke's with time and treatment. Within hours, your ophthalmoplegia will resolve. And remember, all the classic triad is, the entire three classic triad is seen in less than 20 to 30%. As I told you, in medicine, whenever you call classic, it will be seen only in 20-30% of the cases. It's not common. And among the three things, the most common that you get is actually the confusion. And that's the last thing to resolve also. But nevertheless, that's the most common, presentation of a Wernicke's encephalopathy. Confusion is going to be the most common. And treatment is going to be the thiamine. But one more important entity is, if you're giving, thiamine treatment, and it appears that it's only partially resolved. It's only partially resolved, and it's not completely resolved. And if you think still the patient is having some confusion, then you have to deeply analyze, because it could be a Korsakoff amnestic syndrome. It could be a Korsakoff psychosis, or currently we call it as a Korsakoff amnestic syndrome. Suspect Korsakoff amnestic syndrome in that setting, because Korsakoff amnestic syndrome can coexist with Wernicke's encephalopathy, and because patients having ataxia ophthalmoplegia, you will be thinking more of a Wernicke's encephalopathy in that setting, and you will not be able to diagnose Korsakoff amnestic syndrome. But once you give thiamine treatment, the Wernicke's encephalopathy will completely resolve, and now the Korsakoff amnestic syndrome that is already present in the patient will start getting unmasked. So what is the Korsakoff amnestic syndrome? It's more of an amnesia. We know that. That is due to the mammillary body or thalamic nucleus destruction, because we know the memory circuit. But more than that, memory is coming from different areas, which we'll be seeing subsequently. But as far as memory is concerned, the traditional thinking is that kind of a Papez circuit we have, that is mammillary body, anterior nucleus of the thalamus, cingulate gyrus, and hippocampus. This is the memory circuit that we know, isn't it? That's called a Mark circuit, or that is what we refer to as a Papez circuit. Again, we don't want to discuss in detail about that, because that's total physiology and not a high yield information. So now currently we know that Papez circuit is nonsense, and we have a lot of other areas also that is involved in memory. So because hippocampus, the thalamic structures are severely damaged in the setting of alcohol and thiamine deficiency. So you might result in kind of an amnestic syndrome if it's severe enough. That's called Korsakoff amnestic syndrome, which can uncover itself or it can manifest once the underlying Wernicke's encephalopathy is treated, which means thiamine treatment can unmask the Korsakoff amnestic syndrome. So features will be confabulation, or I can remember like a rack. Rack is easy to understand because whenever you remember this mnemonic as a coat, it is easy to remember this as a rack because coat rack is very easy to understand. So rack stands for retrograde amnesia, amnesia for the events that happened before, and anterograde amnesia, amnesia for the events that happened after. That's anterograde amnesia. Both will be there, and more important feature is going to be the confabulation. So anytime whenever I ask about confabulation, students will tell memory gaps. I mean, we have to really know what you mean by memory gaps, and this is Korsakoff. The most important feature here that will be important in exams to diagnose this disorder is the confabulation. That's going to be the most important. So what is confabulation? I mean, yes, correct what you tell. It's form of memory gaps in between that the patient tries to fill up. But it looks like as if the patient is lying, but the patient is actually not lying. Because what is confabulation? Suppose if you have, the patient has forgotten something and it doesn't want to really accept this mind state itself will not accept that it's a forgotten memory. He tries to fill up his gap with some other memory. So classic example is when you you always have to keep an attender with you. That's really important. So when you have a wife and a husband is suffering from Korsakoff amnestic syndrome because of excessive alcohol, you interview them, you ask them morning, what did you have for breakfast? They might tell, I had idli. Maybe yesterday morning, what did you have? They will have idli, probably. That's what they were going to tell. And if you ask the wife, they will tell, no, they didn't have idli. So then why is telling it's idli? Because maybe 3 days back or 4 days back, you would have had idli. So what he's trying to do is morning, you would have had dosa, but he doesn't know it. So he's trying to take that data, which is having in the previous day, maybe in that day morning, 3 days back, you took idli and is trying to fill that gap with another memory. So this is what we typically call it as a confabulation. It looks as if the patient is lying, but no, it's not a voluntary thing. It's a very spontaneous thing. So when you examine the patient alone, you will not feel anything that's sort of a lie or a problem. But only when you have an attender, they will tell, no, it's not. The patient is telling something different. So this is again a part of amnesia and a cognitive dysfunction only. You can call this as a confusion if you want. But since it's only in one domain, I don't really call it as a confusion, and it's going to be there for more period of time. So I will not be really called as a confusion. It's a cognitive type of a dysfunction. It's a kind of a neurocognitive dysfunction. So that's what we call it as a confabulation. Confabulation is there because the patient has lost memory, both anterograde as well as retrograde. So last thing what he remembers, he tries to fill that in that particular gap of memory what he's having. So this is confabulation. And why I told you this is because in exam, very commonly you will misdiagnose this Miller-Fisher with Wernicke's encephalopathy, where you have to be a little careful because even Miller-Fisher can produce encephalitis. So that is the reason why it undergoes the importance of MRI also, because in Miller-Fisher syndrome, if the patient comes with confusion, it still could be due to encephalitis that the patient is having. But mostly in Miller-Fisher syndrome, you will be seeing changes in the brainstem. But in Wernicke's encephalopathy, you will be seeing changes in the mammillary body and the thalamus. Okay, I think every patient, Riju is telling every patient has it when HOD professor arrives after we have taken history. Yeah, correct to an extent. That is because the patient knows. In an institutional setup, patient knows who's a student and who's a HOD. Like whenever the student comes, like they don't really care. Like they will tell whatever they want. But when HOD comes, they know they are the ones who are going to really give treatment, isn't it? So that's why they change and tell. It's not like they change and tell. They don't give proper attention to a student because they know the student and the professor, whoever it is. So professor means they take it a little serious and they answer it properly. But if it's a student, they will be like, okay, relax. Okay. Anyway, they're going to torture me. 5-10 people are going to come and ask me questions in the next 3-4 days. They know that. That's why probably they don't answer well. Okay. Now, what else we can do? Because having discussed on the peripheral neuropathy, we can discuss on muscle disorders. And more importantly, before going to the muscle disorders, we have the neuromuscular junction disorders of which the myasthenia gravis is going to be more important. And we have another disorder like LEMS, we have botulism, so many entities are there. But before that, we need to understand what's happening in the synapse in a short nutshell. You have a presynaptic terminal like this, of course. Then you have a postsynaptic terminal. As far as the postsynaptic terminal is concerned, it's going to be made of multiple crests and troughs like that. So this is a postsynaptic terminal. And we know classically one disease is there, that is myasthenia gravis, which is a postsynaptic disease. I've told you multiple times in the past. So for example, you have this acetylcholine receptor for the acetylcholine molecule that is present on the crest usually. So these are the acetylcholine receptors I'm talking about. So in the presynaptic terminal is going to release acetylcholine. To release acetylcholine, they're going to come from vesicles. And again, how the vesicles are docking. And there are a lot of molecules that are like synaptophysin, synaptobrevin. So many molecules are there that are going to help in docking of this acetylcholine vesicles to release acetylcholine. But nevertheless, now it's not really important. I'm going to cause release of acetylcholine molecules. These acetylcholine molecules are going to act on acetylcholine receptors. Once they act on acetylcholine receptors, they are going to open up certain channels. So remember, these acetylcholine receptors are NM type of receptors. So basically, what are NM type of receptors? They are nicotinic type of receptors, and in the sense like they are ion channels, neuromuscular junction type. So nicotinic NM means stands for neuromuscular junction type receptors. So which means these nicotinic receptors are basically nothing but ion channel type receptors, which means there's going to be some ion release into the postsynaptic terminal. That is absolutely going to be the sodium as you predict. This sodium now will stimulate the sarcotubular system. So once they depolarize the sarcotubular system, you are going to result in production of calcium, release of calcium through the sarcotubular system. And this calcium is of course going to result in muscle contraction. Simplified way how we can understand what's happening in neuromuscular junction. And to release this acetylcholine molecules, you need a lot of other events to happen in presynaptic terminal, which means it has to first depolarize. So which means this depolarization that is coming up is going to open up certain calcium channels. And this calcium is the one that is going to cause the docking of the synaptic vesicles and release of the acetylcholine molecules into the synaptic space, and further action of acetylcholine will be taking place after that. So release is mediated by calcium, and many other presynaptic proteins are also there, but calcium is going to be the most important. There are many different types of calcium channels here. Of course, the most important type will be the L-type calcium channels. That's the most important. And apart from that, we have this PQ type of calcium channels also. And this is also important because it's involved in a disease called LEMS. That's why this is important. And there are many diseases that can affect this particular neuromuscular junction. One is going to be the myasthenia gravis, MG, that is going to be typically a postsynaptic disease. Which means why? Because it's due to a problem of the acetylcholine receptor. So for example, in myasthenia gravis, you have antibodies that are going to damage the acetylcholine receptors. These are acetylcholine receptor antibodies. And you have a lot of other antibodies also. Other antibodies are there, like anti-MuSK antibodies are there, which we'll be discussing subsequently, and anti-LRP4 antibodies are there, anti-actin antibodies are there. So many different types of antibodies are there, but commercially used is only acetylcholine receptor antibody in majority of the centers, and sometimes you can use anti-MuSK antibodies also. And we have anti-LRP4, anti-actin. Anti-LRP4 is available in certain centers, but not all the centers. But where is this MuSK protein? As far as MuSK protein is concerned, you can draw the MuSK protein over here, maybe in the troughs, not in the crests. In the crests, you have this acetylcholine receptors, and that presence of acetylcholine receptor in the crest is really, really important, because in this setting, you will have a short distance for the acetylcholine molecules to reach the postsynaptic terminal, because acetylcholine has an extremely short half-life. In the sense, it will be rapidly disintegrated by acetylcholine esterase into choline and acetyl-CoA, right? We know that. And this choline acetyl-CoA will be taken back by the presynaptic terminal, and they'll be used to resynthesize the acetylcholine molecule once again. So this is very important. Again, it's rapidly disintegrated by the acetylcholine esterase enzyme. So that's why it's very important to make the action as fast as possible. That's why these acetylcholine receptors are basically put on the crests, not on the troughs. But you have another molecule called MuSK, that is muscle specific kinase, that generally tends to be present on the troughs of the postsynaptic terminal, where it regulates the density of the acetylcholine receptors. So the amount of acetylcholine receptors and the density of the acetylcholine receptors on the postsynaptic terminal, that on the troughs, is regulated by the MuSK. One of the important things that regulate is the muscle specific kinase. So that is the thing that regulates the density of the acetylcholine receptors on the crests of the postsynaptic terminal. So any problem in this can result in a lot of issues. For example, what happens in myasthenia gravis? I mean, whatever may be the fact, you can understand that myasthenia gravis, irrespective of the antibody that's been there, it's actually a postsynaptic disease. It's not a presynaptic disease. So that is not something to be confused at all in the first place. Clear? And what happens? So whenever you have an antibody, for example, let us assume you have an antibody against acetylcholine receptor. So I'm going to draw here, maybe I can draw in this color. So you have antibodies that are target against this acetylcholine receptor. It's an autoimmune disease. It's a type 2 hypersensitivity reaction. Why it's type 2? Because you are basically having antibodies against acetylcholine receptor. So it's a form of a type 2 hypersensitivity only. These antibodies does a lot of things. In the sense, first thing, what these antibodies causes, you think they block the acetylcholine receptor, right? These are called as blocking kind of antibodies, but actually it is not a common mechanism. So many students think that way, that blocking of this acetylcholine receptor by the antibody is the reason for development of myasthenia gravis, but blocking is not a common reason for development of myasthenia gravis, even though you do have blocking antibodies, but blocking is not a common reason. Instead, what they do is these antibodies reduce the density of acetylcholine receptors. Density of acetylcholine receptors. The reason for reducing the density is because antibody mediated damage will damage the acetylcholine receptors, and at the same time, these antibodies are going to cause complement activation. Complement activation. Once they cause, because these are IgG antibodies, and to an extent they can activate the complements. Yeah, they can damage MuSK also. We are talking about an example, acetylcholine receptor antibody. That's all. So complement activation. This complement activation will result in complemented damage to the postsynaptic terminal. And because they damage the postsynaptic terminal, the number of acetylcholine receptors will be less, because the muscle will not release, and they will try to internalize as much as acetylcholine receptors are possible. Because I know the moment you come out, you're getting attacked by a lot of antibodies and complements. So they will try to reduce the amount of acetylcholine receptors that they're getting expressed. So the density of the acetylcholine receptors is reduced because the complement attack. And number 4, at the same time, the folds will be lost. The folds will be lost and they will become flat. So, and again, that is due to damage by the antibodies and the complements. Once the complements antibodies damage this postsynaptic terminal, so the folds will be lost and you will get a straight line. I mean, in the sense like a flat postsynaptic terminal. If your postsynaptic terminal becomes flat, it will take a long time for acetylcholine to reach the postsynaptic terminal. That's deleterious, because acetylcholine is something that has to be used very rapidly. So that is the reason why you have crests, and that is the reason why it is actually placed there. But if you don't have this kind of folds, and if you have a flat postsynaptic terminal, it takes a long time for the acetylcholine molecules to reach the postsynaptic terminal. And by the time the efficacy of acetylcholine will be lost, because a lot of acetylcholine molecules will be metabolized by the acetylcholine esterase. So the amount of acetylcholine that is reaching is also quite less. So, and these are the reasons why, like myasthenia gravis produces some typical findings like fatigability, that kind of fluctuating weakness, why diurnal variation is there. And more the acetylcholine is, more the amount of acetylcholine that are going to reach the postsynaptic terminal. And lesser the acetylcholine is, less number will reach. Depending on that, your power will vary. So that's why you get that easy fatigability. The more they do work, the faster they get fatigue, because amount of acetylcholine released will be less at the later stages. So once they release less, the amount that will reach the postsynaptic terminal will become very less. So they'll go for fatigue and weakness. And if you think only kind of a blocking kind of an antibody, then it will become really difficult, because if it's only blocking mechanism, then of course, like you should not get like this kind of fluctuating kind of a weakness. So antibodies are anyway going to block this acetylcholine receptors. So anyways, so many findings are there, so many pathophysiology are there, but nevertheless, students will still believe that blocking is the most common event, but that's wrong. And as far as the presynaptic disorders are concerned, there are two presynaptic disorders that you need to know that can produce neuromuscular junction problem. One is botulism, of course, quite more common compared to that of the limbs. That's why botulism is important. Botulism is going to prevent the docking of the acetylcholine receptor, acetylcholine vesicles to the presynaptic membrane. That's what botulinum toxin does. It's a typical exotoxin. And as far as you know, the botulinum toxin is going to be the most powerful exotoxin ever produced by anyone in the world. You would have studied that number, isn't it? Just 250 milligram of botulinum toxin is enough to kill the entire human race. Just 250 grams of botulinum toxin. It's a very clear, like biowar agent also. And the problem is how to produce that much botulinum toxin. Even producing 2 nanograms of botulinum toxin creates a lot of cost. And to produce 250 grams, it's a huge task. But if you just have 250 grams of botulinum toxin, that's enough to wipe out the entire human race. It's a very, very powerful exotoxin known to mankind. And we know botulinum toxin is going to produce a kind of a food poisoning. That's where very commonly we encounter more than bioterrorism. So where you eat some kind of a canned food. In exam, there will be history of canned foods. And with this kind of a canned food intake, patients will start developing weakness, and they will come with quadriparesis most often. And more importantly, in exam, the clear-cut clue for botulism is they'll produce constipation. That's very important. Reduce bowel movements, because it really reduces the release of acetylcholine, means parasympathetic system is not acting effectively. So you will result in more of a constipation than diarrhea. Perhaps whenever you think about a food poisoning in exam and there is a constipation, think about botulism. Most of the food poisonings will produce only diarrhea and not constipation. And weakness, constipation. And third thing the examiner likes to give is blurring of vision. Why blurring of vision? Because it's a presynaptic disease. If it's a presynaptic disease, any presynaptic disease, if you take in world, they can, affect the skeletal muscle as well as the smooth muscle. Skeletal muscle as well as the smooth muscle. Because acetylcholine is needed for muscarinic receptors as well as acetylcholine is needed for your nicotinic receptors also. So whenever acetylcholine release is reduced, it's going to equally affect both muscarinic receptors as well as nicotinic receptors. So you're going to get autonomic symptoms as well, smooth muscle problems also. That's why you get that pupillary involvement because of muscarinic receptor dysfunction resulting in blurring of vision. But on the other hand, if you take postsynaptic disease, so it's very clear that these antibodies are basically direct against the neuromuscular type of receptor, that is NM type of receptor, because it's going to affect only the NM receptors. Myasthenia gravis, the typical entities, it affects only the skeletal muscle. There will be no smooth muscle involvement. Smooth muscle involvement will not be there. In the sense like autonomic dysfunction will not be there. ANS will be perfect. ANS dysfunction is not a feature of a myasthenia gravis. If you see any pupillary blurring, if you see any bladder bowel involvement in a patient with myasthenia gravis, then your diagnosis is wrong. It is not myasthenia gravis. Myasthenia gravis, by definition, it should have only skeletal muscle involvement. It should not have any autonomic nervous system findings or smooth muscle involvement for that matters. So botulism can cause that because it's a presynaptic disease which is going to affect both skeletal muscle and smooth muscle. Second disease, which is a presynaptic, which affects the calcium channels. We know, everyone knows that is LEMS, rare disease. What's else important to know? That's called Lambert-Eaton myasthenic syndrome, which is typically a presynaptic disease. And once again, this patient will have weakness, more of a girdle weakness, which we'll be discussing subsequently. And they're going to have autonomic features, ANS features like bladder bowel weakness, which is definitely not a feature of myasthenia gravis. ANS features will be there because they affect the smooth muscle also. And the antibodies are typically direct against this PQ type of calcium channels. So these antibodies are also referred to as something called a anti-VGCC, called as anti-voltage gated calcium channel antibodies or anti-VGCC antibodies. The most common reason for development of this VGCC antibodies is the lung cancer, typically the small cell cancer of the lung. So which means LEMS is 90% or even 100%, I can tell in real life, it is a paraneoplastic syndrome. It's very rare to get an idiopathic MuSK. Usually there will be an underlying cancer. Idiopathic LEMS, sorry. It's very rare to get an idiopathic LEMS. Whenever you get a LEMS, it's always paraneoplastic. And if you have a underlying LEMS, I mean, if you have a LEMS type of picture, the next step is to do a CT chest, because it will be due to a cancer always. They will ask you, they will give a LEMS kind of a picture, and they will ask you what is the next investigation. You go for CT thorax because it's a cancer. That's all. Okay. I think we have discussed enough about this presynaptic disease versus postsynaptic disease. The final take-home point is presynaptic disorders may have autonomic features, and postsynaptic disorders like myasthenia gravis will not have autonomic problems. They will not have bladder bowel involvement. That's the most important point to know. And as far as the epidemiology, now we'll go to the core of myasthenia gravis. Core myasthenia gravis. I'll reduce a little bit also. As far as the core myasthenia gravis is concerned, we want to think about the epidemiology first. What age groups are generally affected? Remember, it's a biphasic disease. It has a biphasic, typical biphasic pattern where you'll have two different age groups which will be affected, and the peaks will be at two different age groups. One is 20 to 30 age group, younger age group, that will be very commonly affected. Second is the 60 to 70 age group, older age group. Typically speaking, this 20 to 30 age group usually will be females, and the 60 to 70 age group typically will be males. And very commonly, this younger patients who are affected will have thymic abnormality, some kind of, see, I'm not talking about a thymoma. And the moment I tell thymic abnormality in myasthenia, you always think about thymoma. Remember, thymoma is a rare entity in a myasthenia gravis. I'm talking about some form of thymic abnormality will be there. And most of the patients will have acetylcholine receptor antibody positive. Many of them will be acetylcholine receptor antibody positive, which means younger patients have a higher chance of being AChR positivity. Whereas older patients usually will be males. And some textbook also give older patients will not have any difference in sex, but older patients are known to be more males, but even at least equal sex preponderance. You can remember like that also. Generally, they don't have thymic abnormality. Most of the time, they don't have this acetylcholine receptor antibody also. That's really, really important. And now you'll ask me, if it's not thymoma, then what is the thymic abnormality that will be encountered in these patients? Most common thymic abnormality that is encountered in patients with myasthenia gravis is thymic hyperplasia, and not a thymoma. And of course, thymoma can be there, but thymic hyperplasia is going to be the most common. Which means if there is a thymic abnormality, 85% of the times it will be thymic hyperplasia only, and only 15% of the times the patient will have a thymoma. And a very important clue in exam for a thymoma is the fact that these patients may have, anteromediastinal mass in X-ray or CT. If they give anteromediastinal mass and they give a patient with features that are suggestive of neuromuscular weakness, then of course the diagnosis myasthenia gravis. Of course, very common association in exam. But remember, this thymic hyperplasia will not cause anteromediastinal mass. It's just a histological finding, hyperplasia, but it's not a anteromediastinal mass. If they give anteromediastinal mass, which means it's a thymoma only, because there are certain T's that you need to know. It's a differential diagnosis. Every radiology teacher would have taught this. What is the differential diagnosis for anteromediastinal mass? You have teratoma, you have thymoma, you have thyroid, that is retrosternal goiter. You have some terrible diagnosis. These are the 4 T's. What are the terrible diagnoses? Aneurysms of the aorta. Or you have lymphomas. Terrible diagnosis. So 4 T's: thymoma, thyroid, then you have teratomas, then you have finally terrible diagnosis, that is lymphomas and the aneurysms of the aorta. So it's one of the differential diagnoses for anteromediastinal mass. In exams, neuromuscular weakness, anteromediastinal mass is equal to myasthenia gravis, because they're trying to tell it's a thymoma. Remember, hyperplasias usually will not cause mediastinal mass. Only after thymectomy you can find out it's hyperplasia. Nevertheless, we suspect hyperplasia whenever the patient is having acetylcholine receptor antibody, especially if the patient is young also. Clinically, we can suspect patient might be having some form of thymic abnormality. That's number 1. So this is something you need to note as a background. And next, what are the antibodies that are associated with myasthenia gravis to start with? And we know one is the acetylcholine receptor antibody, which is seen in approximately 70 to 80% of the individuals. And we have anti-MuSK antibody, that is muscle specific kinase antibody, which is seen typically in 4 to 5% of the individuals. And we have anti-LRP4 antibody, which is typically seen in approximately 2 to 3% of the individuals. Other antibodies are there, but We don't test that clinically. But currently, like you can see that almost 90% of the cases, 85 to 90% will have some antibody positivity. Antibody positivity is seen in almost 90% approximately. So I can write around 80 to 90% will have antibody positivity. And there can be around 10 to 20% where they are antibody negative. And these patients were originally called as seronegative myasthenia gravis. But please understand the fact this is a complete nonsense again. There is nothing like a seronegative myasthenia gravis. This is called a seronegative just for our understanding. Commercially, we don't do those antibodies, which means these 10 to 20% of the cases also will have some form of antibody, like anti-actin antibody. There are almost 150 to 200 antibodies that have been discovered that are associated with myasthenia gravis. But it doesn't mean that they don't have antibodies, even though typically, clinically, we call them as seronegative and myasthenia gravis because we don't test for those antibodies commercially. That's why they call seronegative. But really, if you take the pathophysiology of disease, they are still seropositive only. They are not seronegative because there are some antibodies which we are not measuring and they are still done in research practice. So the term seronegative myasthenia gravis goes only towards your clinical diagnosis, but pathophysiologically, there is nothing like a seronegative myasthenia gravis. Myasthenia gravis is always seropositive. There will be some antibody that is causing the trouble. But as far as acetylcholine receptor antibody is concerned, there are some specific features which can be seen in the patient. And anti-MuSK antibody will produce some specific features, and anti-LRP4 antibody will also produce certain specific features. For example, when you take an anti-MuSK antibody, because acetylcholine receptor antibody is basically considered to be the standard. So compared to the acetylcholine receptor antibody related myasthenia gravis, your anti-MuSK antibody will have a little bit more of a cranial nerve involvement and bulbar involvement, which means increased neck weakness will be there in these guys compared to the of the acetylcholine receptor antibody. Relatively more cranial nerve involvement and more bulbar involvement. Because of that, there is increased risk of respiratory failure also compared to the acetylcholine receptor antibody. As far as the anti-LRP4 antibody is concerned, these patients will have more ocular and limb weakness, and they will have a reduced bulbar and respiratory weakness. Reduced bulbar weakness, and they'll have a relatively more ocular and limb weakness, which means the type of antibody also can tell you a probable clinical nature of the disease, which means currently, whenever you take an autoimmune disease, it's the antibodies that determine what clinical feature you have to get. It's not the disease variations. Now, currently, any autoimmune disease you take, the idea is completely changing, that it's the antibody that's going to tell you what kind of disease you're going to, what kind of picture you're going to get. And depending on the number of, the presence of clinical features will vary. So anti-MuSK, more cranial, more bulbar, more neck weakness, more respiratory failure. As far as anti-LRP4 is concerned, they're going to have more ocular and limb weakness and a reduced amount of bulbar weakness. Acetylcholine is considered to be a criterion standard. It's a neutral. We'll be discussing about that after some time. And it's the most common antibody that is present in myasthenia gravis as well, 70 to 80%. So remember, these antibodies are mutually exclusive. So what do you mean by the fact mutually exclusive? Mutually exclusive really means only one thing, that the patient will have only one antibody at a time, which means either they'll be having acetylcholine receptor antibody, or they'll be having anti-MuSK antibody, or they'll be having anti-LRP4 antibody, which means they will not be having two antibodies at a time. It's not possible to have acetylcholine receptor antibody and anti-MuSK. It's not possible to have anti-MuSK and anti-LRP4. Only one antibody will be there at a time. So that is also the reason why we have a seronegative myasthenia gravis in the first place. Otherwise, some antibody will be still present, isn't it? So that's one idea. And other antibodies used, even though first antibody I'll be testing in myasthenia gravis is acetylcholine receptor antibody only. If it is negative, then only I'll be testing for anti-MuSK. Otherwise, I'll not even test for anti-MuSK. If acetylcholine receptor antibody is positive, then that's all. So I'm not going to test for anti-MuSK at all because they're mutually exclusive and they're not going to be presenting together. So only if it's negative, I will check anti-MuSK. So as I told you, around 80 to 85%, around 80% will have, let us assume 70 to 80% will have acetylcholine receptor antibody positivity. And in patients who are having acetylcholine receptor antibody negative, 15% of the patients will have anti-MuSK positivity. Anti-MuSK positivity, which means I can tell that 15% of overall 15% of acetylcholine receptor negative patients will have anti-MuSK much positivity. That's why overall it will come to a range of around 4 to 5%. That is the basic idea. So which means these antibodies, the most important point to know is they are mutually exclusive. They will not be present together. That's one important point. And next, moving on to the clinical feature of myasthenia gravis. So what are the clinical features of myasthenia gravis? As far as clinical features is concerned, the number one and the first point is the fluctuating weakness that these patients have. Fluctuating weakness, number one. So what do you mean by fluctuating weakness? They're going to be easily fatigable. They'll have easy fatigability. So which means the weakness will become worse with repeated use of the muscle. And they'll be completely relieved with rest. And the weakness is going to definitely increase with repeated use of the muscle. So that's what we call it as an easy fatigability. And we know it's a fluctuating kind of a weakness. And because the same reason, the patient may have diurnal variation also. One second. Because the same reason, the patient may develop something called a diurnal variation also. Why diurnal variation really? Because in the morning you'll be using the muscles, like less. As the day goes by, your usage of muscles will increase, and the patient will get more and more fatigued. Which means in the evening and the nights, the patient will have more fatigue than the morning. So this is what we refer to as something called a diurnal variation of the muscle. And what are the muscles involved? What group of muscles will be involved? Typically, the features will be proximal muscles. Proximal muscle involvement is very characteristic, and more importantly, you are going to have ocular weakness. Ocular muscles, especially the extraocular muscles, very characteristic. If somebody asks you what is the most common muscle group that is involved in myasthenia gravis, it's again ocular muscles that are commonly involved in myasthenia gravis. And most common clinical feature is going to be ptosis. Ptosis is going to be the most common clinical feature of myasthenia gravis, or a clinical sign of myasthenia gravis, maybe. So proximal weakness means we are talking about limb weakness here. Limb weakness is typically proximal. If it is proximal, in the sense, there should be some characteristic findings, isn't it? So in the sense, like this limb, whenever you examine these limbs, they will of course have proximal weakness, but they tend to have normal tone and normal deep tendon reflexes, which means there will be no reduced or increased deep tendon reflexes, and there will be no atrophy. Atrophy is not a feature, and 100% surely won't get fasciculations. So no atrophy, no fasciculations, normal tone, normal deep tendon reflexes. That's why it's a very difficult disease to diagnose basically. Unless if you have ptosis, or second ocular reason could be diplopia. Even because of that, they will be presenting. But like it's very difficult disease to diagnose if you do not have a ptosis or a diplopia. And if you have only limb weakness, which can happen in certain types of myasthenia gravis at presentation. So in that setting, it's very difficult to diagnose. You will have this fluctuating kind of weakness, all right, but the patient will have a completely normal tone, normal DTR, no atrophy, no fasciculations. How will we be able to diagnose this? It's very difficult. They have ocular weakness, and that's the key. Fortunately, ocular weakness is extremely common in myasthenia gravis, and no patient with myasthenia gravis can be having a disease without developing ocular weakness at some point of the lifetime. Which means they can present with limb weakness alone, but at some point of time, they will surely develop ocular weakness. For example, at presentation, like the patient may have either ocular weakness or generalized weakness. Ocular weakness or generalized weakness at presentation. Remember, at some point of time, almost 85% of the times, 85% of the times, at some point of time, even if they present with generalized weakness, the course will be in such a way that they will develop surely ocular weakness at some point, which means all these generalized weakness patients, even if they present with only limb weakness initially, at some point of time, they'll get generalized weakness, and that's called a generalized myasthenia gravis. Generalized myasthenia gravis, which means even if they start with generalized weakness, at some point of time, they will surely develop ocular weakness, and that is what we call as a generalized myasthenia gravis. Or I can write limb weakness here, otherwise you'll be more confused. So I'm getting to start with, they will be having limb weakness, but at some point of time, they will surely develop some form of ocular weakness. So, and that's called a generalized myasthenia gravis. Which is in 85% of the cases. And in 15% of the cases, where they start with ocular weakness, they will not get the limb weakness at all, and these patients will have ocular only myasthenia gravis, called as ocular myasthenia gravis. So 15% of the times they will have only ocular weakness throughout the course of the disease, that is ocular myasthenia gravis, and in 85% of the times they tend to have both limb and ocular weakness. That's called a generalized myasthenia gravis. In 15% of the times they're going to have ocular only disease. But at presentation, it can be anything. But even though most common is again ocular weakness only, even at presentation, most common feature is ptosis. But still, some patients may come only with limb weakness to start with. But eventually, they will develop ocular weakness for sure if the disease is myasthenia gravis. So which means if you take the overall picture and see, in the course of the disease, all patients should develop ocular weakness. If there is no ocular weakness, it is not myasthenia gravis. That's why whenever you talk to a CME or when you talk in exam, if they ask you myasthenia gravis, why it is not myasthenia gravis? The two things that you have to substantiate is there is no fluctuating weakness. That's the most important point. Fatigability and fluctuating weakness is not. That's the first point you're going to tell. Second point, of course, you're going to tell is there is no ocular weakness. That's what you're going to tell. Because if you tell these 2 points, no fluctuating weakness, no ocular weakness, examiner believes, like that you know something about myasthenia gravis. So that's the 2 quintessential points of myasthenia gravis. So don't forget the ocular weakness and the fluctuating weakness part. And there is something called a myasthenic crisis. So what do you mean by myasthenic crisis? These patients tend to present with respiratory failure rapidly. That is because of sudden increase in the weakness of the skeletal muscle. Even diaphragm is also skeletal muscle. That's why they can present with respiratory failure. Any patient that presents with respiratory failure is what we call as a myasthenic crisis. And 2 things. It's going to be due to exacerbation, due to some reason. So what is the reason for exacerbation? Number 1, stressful events can precipitate a crisis. Especially, for example, if the patient gets a URI, upper respiratory infection, they can end up in a stressful scenario, or any infection can cause stressful scenario in the body that can precipitate the development of myasthenic crisis and respiratory failure. Second, doing a surgery. Again, it's a kind of a stress only to the body, so they can develop myasthenic crisis. And during pregnancy and postpartum period. Pregnancy and postpartum period, one other reason why the patient might end up with stress and they can go for myasthenic crisis or something like an exacerbation. Remember, exacerbation means increase in weakness. Crisis means respiratory failure. So, I mean, both are almost the same only, but small difference is there. Exacerbation, crisis. Exacerbation means increase in weakness. Crisis means the patient not only will have increased weakness, the patient will have respiratory failure also along with that. So all these things can be done by stress, surgery, pregnancy, postpartum, and certain drugs. So what are the drugs that can exacerbate myasthenia gravis is a very common question in exam. Usually I tend to give a mnemonic. Generally I hate mnemonics, but unless until you give some mnemonics, nobody will like you. So especially a NEET PG aspirant or any undergrad medical student will never like you if you don't give a mnemonic. So I'll give a mnemonic called ABCD. So A stands for antibiotics. A lot of antibiotics can exacerbate myasthenia gravis and can even result in development of crisis. The most important antibiotics are going to be aminoglycosides. Harita is asking why you hate mnemonic, because that makes me forget the concepts. That's why. And that's actually making me not understanding the subject. That's why. So one is aminoglycosides, number 1. And second is we have macrolide antibiotics. Macrolides, and at the same time we have fluoroquinolones as well. So aminoglycosides, macrolides, fluoroquinolones. Can patient present directly with crisis exacerbation without previously a known case of myasthenia? Yes, of course possible. But in that setting, you will be diagnosing a patient with respiratory failure, and your treatment will be the same. Almost you're going to treat how you're going to treat a patient with respiratory failure, like intubation and mechanical ventilation. And that's going to be the key. And once you analyze later on what is the reason for respiratory failure, seeing the ABG, type 2 respiratory failure, then you analyze the cause of type 2 respiratory failure. So in that, it could be a GBS or it could be a something else. So when you evaluate for GBS or nerve conduction study will not show any features of GBS, then you think about probably some other reason like myasthenia, then you do an antibody, it will be positive. That's how you pick up. The patient directly comes with myasthenic crisis, but they can come. It's not like nothing is impossible. And we have seen some 2-3 guys who come straight away with crisis. Both of them had a thymoma, for that matters. Anyway, so one is antibiotics, aminoglycosides, macrolides, phenolphthaleins. These can result in development of crisis, and B stands for beta blockers, and C stands for chloroquine. And more importantly, more than chloroquine, it's the quinine, original quinine, that can exacerbate myasthenia, and D stands for D-penicillamine. And E, I generally tend to give some miscellaneous or extra drugs like, for example, phenytoin can exacerbate myasthenia gravis, then procainamide can exacerbate myasthenia gravis, then interferons, interferon alpha, beta, alpha used for hepatitis, beta used for multiple sclerosis, we discussed already. So that can exacerbate myasthenia gravis. Magnesium sulfate. This is very important because if there is a pregnant woman with myasthenia and they develop preeclampsia or eclampsia, magnesium sulfate is very dangerous in that setting. I mean, instead you have to give magnesium sulfate. There is no other go if the patient goes for eclampsia. But nevertheless, you have to keep in mind that this can worsen the myasthenia very badly. Even pregnancy itself is going to worsen. Coupled with that, giving a magnesium sulfate can worsen more, and you have to be prepared for intubation in these guys, in these ladies especially. Okay, so this is myasthenia gravis. Clear. At the same time, when the patient is taken for surgery, whenever a patient with myasthenia is taken for surgery, and the most usual surgery will be a thymectomy. Whenever you think about a myasthenia gravis patient, the most common surgery done in them is thymectomy only. And we do elective thymectomies also, even without a thymoma, that we'll be discussing in some time. So in that setting, one thing you have to understand is when you're going to use a neuromuscular blocker, when you use a depolarizing neuromuscular blockers, the dose required is actually more, like succinylcholine. If you use a depolarizing neuromuscular blocker, the dose that you will require is actually more. Why? Because succinylcholine acts on the acetylcholine receptors, and they're going to, like continuously stimulate the muscle so that you will result in, like fatigue of the muscle, and then it causes weakness. That's why choline causes weakness. We know that. So it's a depolarizing neuromuscular blocker. But you can remember choline like acetylcholine. Acetylcholine and choline are almost same only. But when you give excess choline, it is going to act like acetylcholine, and they're going to cause rapid contractions and fatigue of the muscle. But in myasthenia gravis, the amount of acetylcholine needed to produce contraction is more. Similarly, the amount of choline to produce contraction and subsequent fatigability is also more. So, which means the choline dose, the depolarizing neuromuscular blocker dose that you need in myasthenia gravis is actually very high. And second thing, non-depolarizing neuromuscular blockers. These are going to block the acetylcholine receptors, thereby preventing the acetylcholine from acting on the muscle and thereby causing weakness of the muscle. So that is the mechanism of action of non-depolarizing neuromuscular blockers like vecuronium, rocuronium, atracurium. So if you're using a non-depolarizing neuromuscular blocker in surgery, the dose needed is actually quite less, because the non-depolarizing neuromuscular blockers are doing the same thing as what antibodies are doing. They're blocking the acetylcholine receptor antibodies, which means already antibodies are blocking. And now if you give a non-depolarizing neuromuscular blocker that blocks the neuromuscular junction, the dose that required is quite less. In fact, non-depolarizing neuromuscular blockers are very sparingly used in myasthenia gravis patients because they can result in prolonged paralysis after anesthesia, and the patient will take a longer time to recover. That's why they generally tend to avoid non-depolarizing neuromuscular blockers in myasthenia gravis. So two take-home points: depolarizing need higher dose, non-depolarizing need lower dose, and they're very sensitive to non-depolarizing neuromuscular blockers, of course. And clinically, there are some signs are there. What are the tests that you can use for diagnosing myasthenia gravis? Clinical tests are there. The one clinical test that you need to know is an ice pack test. That's very, very important. And this is having an excellent sensitivity and specificity, almost comparable with that of an electrodiagnostic test. That's why this ice pack test is often asked in exam, because one clinical test that can clinch you the diagnosis of myasthenia gravis straight away, because it's having very high sensitivity and specificity comparable to that of a nerve conduction study and electrodiagnostic test. That's why. So what is ice pack test? It's usually used for ocular problems. Whenever a patient is having a ptosis or an ophthalmoplegia, nothing, you just keep an ice pack over that particular eye, and after removing that ice pack, the weakness will get better. So that's what simple test, very simple test, but we don't know the basis of this, even though it's been suggested that antibody dissociation in cold conditions is what is being suggested. But nevertheless, this is a very good test to confirm that it's a myasthenia gravis. It's having very high sensitivity and specificity. That's why it's a very, very common question in many exams, ice pack test. And more importantly, many people do think that myasthenia gravis is symmetric, but no, it's actually asymmetric. If you take the previous discussion, it's actually a kind of asymmetric nature. So which means even ocular weakness, if you take one eye may have a ptosis, another eye may not have a ptosis. I think if you take the previous one, I think it's something we can easily discuss that. I don't know, I think I've written there, I guess. I think it must be there. Isn't it, Dioman? Yeah, we have discussed in the previous session, isn't it? So we told that in neuromuscular junction weakness, the weakness will be more asymmetric. That's why that point is very important, because it's not symmetric. So which means you can have a kind of a ocular weakness that can happen only on one side. E is extra, like that's just to make a mnemonic I made. E for extra drugs. Okay, ice pack test. Ice pack test is going to have a very high sensitivity and specificity, in the sense like they have a good negative predictive value also. Vijay is asking whether it's having a good negative predictive value. Not a very high negative predictive value, but it has a decent, around 80-90% negative predictive value is still there as far as ice pack test is concerned. It's a very good test clinically. That's why that's a very common question. Apart from that, you have something called a Simpson test that relies on fatigability. What do you mean by Simpson test? You just ask the patient to see some object that is on the top like this for some time. So once they are seeing this object on top for some time, because of easy fatigability, slowly the eyes will go for ptosis. So this is what we refer to as Simpson test. And third is the Gorlick test. Gorlick test. This is a very interesting one. And again, we don't know why this happens, but it's very interesting. I mean, the reason is something different. So for example, if you, for example, if this eye is having a ptosis, and if you lift this eyelid voluntarily like this, the opposite eye, which is not having that much ptosis, or opposite eye, which is having less ptosis compared to this eye. So if I assume the right eye, my right eye, this eye is having more ptosis, this eye is having less ptosis or no ptosis. So now if I passively open this eyelid, now this eyelid will go for closure. This eyelid will go for more ptosis. So this is some kind of a one door opening and other door closing. So this is what we refer to as a Gorlick test. And there are a lot of clinical basis for why these tests are happening, but that is nothing needed right now. That's never a high yield, and not even a high yield. It's not going to be useful in clinical practice nevertheless. So these are the basic clinical features of myasthenia gravis. And among all these things, the ice pack test is the most important for exams. And apart from that, you have something called an heterophonium test, which is often confused in exam. I don't know why there is a confusion. There is not. I mean, heterophonium test is completely outdated test. We don't even use heterophonium test right now to diagnose myasthenia gravis. Show me one neurologist or one physician who is basically using heterophonium test for diagnosing. It's only for pharmacology. It's important, because to understand autonomic nervous system, to start as a beginner, you might be needing to know that. But apart from that, once you move into clinical practice, there's nothing like heterophonium test. It's having a very poor sensitivity, poor specificity, even lesser than the ice pack test. So we don't really use. So we have something called, as far as the investigation is concerned, the first thing I want to substantiate is I'm not going to talk about this neostigmine test, or I'm not going to talk about this heterophonium test, because basically they're having low sensitivity and low specificity, and it's completely observer dependent, and it can be used only for ocular myasthenia gravis. You cannot use for generalized myasthenia gravis. Whenever the patient is having ophthalmoplegia, if one of the muscles get improved after giving heterophonium, it is considered to be positive, but still it's completely outdated and nobody uses this test anymore. That is heterophonium or neostigmine test. And second one, we use electrodiagnostic tests. These are the standard testing right now. And we do some tests, like we have single fiber EMG. And this is supposed to be the most sensitive test, 95 to 98% sensitivity, but specificity of course goes down with increasing sensitivity, where we tend to see something called a jitter. Jitter is the classic word that comes out in SFEMG, because if you do a single fiber EMG, there will be delay in neuromuscular transmission. As far as myasthenia gravis is concerned, the most important problem is that delay in neuromuscular transmission. So that delay between, this delay can be variable in different muscle fibers. One muscle fiber may show probably a 15 millisecond delay. Another muscle fiber will show 40 millisecond delay. So delay will be there, but that delay will differ between different muscle fibers, and that delay difference between different muscle fibers is what is going to create a sort of a jitter that will be heard in the single fiber EMG. And that's very sensitive, but not specific, because even in peripheral neuropathies, you might get that delay in the neuromuscular transmission. So it's not very specific, but it's sensitive. So in SFEMG, most sensitive investigation. And as far as other investigations are concerned, you can do something called a traditional EMG, that's called a needle EMG, to rule out other disorders. This is only to rule out other disorders. And we have a nerve conduction study that is rule out peripheral neuropathy. And there is something called a repetitive nerve stimulation. And this is important in myasthenia gravis. Because in RNS, very commonly, if you stimulate the nerve repeatedly, there will be something called a decremental response, because of the fatigability, which means you are demonstrating the easy fatigability of the muscle. And with more and more nerve stimulations, you are going to have more and more decremental response rather than an incremental response. That's very important, because when you go for other disorders like LEMS, Lambert-Eaton myasthenic syndrome, it's going to show something called a incremental response rather than a decremental response in Lambert-Eaton myasthenic syndrome. So in myasthenia gravis, you will get a decremental response with repetitive nerve stimulation. And of course, you do antibody testing. Antibody testing is supposed to be the most specific antibody. Most specific testing for myasthenia gravis. Whatever may be the antibody that is positive, if it's positive, it is myasthenia gravis unless proved otherwise. That's all. They are very, very specific, almost 95 to 100% specificity. And next, you can do a CT and MRI of the chest if you want, because that is to rule out thymoma, not thymic hyperplasia, but basically we are trying to rule out thymoma there, because all myasthenia gravis patients should go for CT chest once the diagnosis is made. Even LEMS patients should go for CT chest, because LEMS in fact even have a more risk of having a underlying small cell lung cancer. So CT chest is mandatory for many neuromuscular junction disorders. That's the take home point. And now coming on to the treatment of myasthenia gravis finally, as far as the treatment is concerned, first ask the question, is the patient is having a thymoma or not? Then if the patient has a thymoma, then in that setting, I'll be doing a thymectomy first. That's the most important treatment. There is no doubt about that, isn't it? Thymoma means you have to go for a thymectomy for sure. The patient is not having a thymoma. In that setting, I'll be treating with the medical management first. Sorry, no, not here. Sorry. The patient is not having a thymoma, then I'll be treating mostly with the medical management. Usual medical management is pyridostigmine. The idea of pyridostigmine is to reduce the weakness, which means it's more of a symptomatic treatment, which means pyridostigmine is an acetylcholine esterase inhibitor. So which means they increase the concentration of acetylcholine in the synaptic space. But to alter the disease pathophysiology, I'll be needing some disease modifying drugs. When I write DMD, you should not think of Duchenne muscular dystrophy. Here means disease modifying drugs. That's what I mean. Again, if I write DM drugs, you'll think diabetic drugs. No, I can write fully disease modifying drugs. So what are the disease modifying drugs? These are basically immunosuppressive agents. Immunosuppression. Currently, like previously it's thought like after pyridostigmine only we give immunosuppression, but in 2019 a Lancet article came which told that immunosuppression is something very important at the early stage itself, because even if you treat symptomatically, the underlying disease process will still be there and the patient will still be moving for more and more damage of the postsynaptic fold, and they go for more complications. So that's why immunosuppression is very important in this setting. Immunosuppression means I can use steroids, I can use azathioprine, I can use other drugs like mycophenolate mofetil, I can use calcium urine inhibitors, I can use even rituximab, because this is an antibody dependent disease. The anti-B cell antibody rituximab is going to be helpful as well. But currently rituximab is more effective for ocular myasthenia gravis. If it's limb only myasthenia gravis, to start with, rituximab is not helpful. But in refractory ocular involvement, rituximab is more effective. That's the statement that is given in many textbooks. But as a matter of choice, like you can go down the ladder at any point, no problem. And anyway, myasthenia gravis patients will have some point of time, they'll have ocular weakness for sure. So immunosuppression can be done. But one interesting point to note that is if you start with prednisolone, steroids, the problem with prednisolone is they can transiently worsen the myasthenia gravis. They can transiently worsen the weakness. It's only for transient time, maybe for a few days or few weeks, their weakness will worsen. But that's one problem because they can even go for crisis. And that's only during the early phase, maybe for a few days. That's all. They have a risk of more worsening. To avoid that, most of the times in Indian scenarios, to give steroids, we admit the patient and then only we give steroids because we believe that giving steroids in home may not be that appropriate because the patient doesn't come or the patient doesn't have anyone in home. He might develop crisis and die in home. So give as an inpatient, but they may not ask you this question, but they will ask you surely that steroid effect transiently, the initial part of the reason, they might basically worsen the disease. And that is basically due to the more association of the antibodies with the acetylcholine receptor, even though it takes some time, but transiently lymphocytes respond to immunosuppression by producing more antibodies. That's what they told. And in any disease for that matters may worsen initially. And myasthenia gravis is shown to have more association, and steroids have direct this muscular effects also. For example, we have studied steroid-related myopathy and all. So they can have direct muscle effects. And again, the reason is not known very clearly, but one reason probably could be direct muscular effects of steroid where they cause kind of a myopathy kind of a thing. The neuromuscular transmission may become weak and lymphocytes can transiently respond to the steroids by producing more antibodies. So whatever. So nevertheless, it will take some time. So you wait on till that. So transient worsening should be expected. And that is the reason why you try to give this steroids as an inpatient, especially in Indian setting. Suppose if you do not get a good response with these drugs, which means patient is having a relentless progression of the disease, then you can think about doing a thymectomy. In that setting, look for acetylcholine receptor antibodies. Number one, if it's positive, and if the age is less than 45 to 60. Various guidelines tell various cutoff. Many of the UK guidelines tell 45. Many of the Western, your American guidelines give 60. Anyway, the idea is to see whether the patient is young or old. That's all. A young patient, acetylcholine receptor antibody is positive. If yes, in this patients, you can go for a prophylactic thymectomy. Because most of the times, these patients will have some abnormality in the thymus gland. So you chop off the thymus. That's why I told you that point in the beginning itself. If no, then the patient has acetylcholine receptor antibody negative, or if the patient is very old, like 70, 80. So in that setting, you can continue with the medical management, continue intensifying the medical therapy, intensifying immunosuppression, and continue the medical therapy as much as possible. This is what you're going to do, which means what I'm trying to tell is thymectomy will not be effective if the patient is not having acetylcholine receptor antibody positivity, or if the patient is very old, thymectomy will not be really effective in those guys. And at the same time, if the patient presents in crisis, myasthenic crisis, if a known case of myasthenia is there, of course, the first thing to do is intubation, and you have to save the life of the patient because they will be in respiratory failure. And then this will be followed by giving some drugs. So what you can do is you have to give pulse methylprednisolone. Most of these patients, you need pulse methylprednisolone because they are in crisis. Plus, you can use either IVIG or plasma exchange. So if they ask you in myasthenic crisis, one more indication for IVIG is patient is in myasthenic crisis. So this is another indication for giving IVIG in this scenario. Or you can use plasma exchange also, not a problem. Any one but. So now examiners will be asking how to differentiate between a myasthenia gravis and Lambert-Eaton myasthenic syndrome. So remember, both can be paraneoplastic. It's not like it's not paraneoplastic, but the antibodies are different. So in myasthenia gravis, the antibodies are anti-acetylcholine receptor antibody, or it can be MuSK or LRP4. We don't want that right now. But as far as LEMS is concerned, the antibody is anti-voltage gated calcium channel antibody, that is anti-VGCC antibody. That's a LEMS, a characteristic LEMS antibody. That is against the PQ channels. And both can be paraneoplastic syndrome. Myasthenia gravis also can be PNS. LEMS can also be PNS. But the chance of myasthenia gravis being a PNS is 15%, which means the usual cancer that's associated with myasthenia gravis is thymoma. As far as limbs is concerned, 90 to 95% of the time the limbs will be paraneoplastic, which means almost always paraneoplastic. The usual cancer that is associated with limbs is small cell lung cancer. And of course, clinically, ocular weakness will be very, very prominent here in the setting of myasthenia gravis, where it will be rare in the setting of a limbs. It can be there, but it's quite rare. And of course, you will have a proximal more than distal weakness in myasthenia gravis, whereas limbs tend to have more of a girdle weakness. It's proximal only, but still characterized by more of girdle weakness. Still it's proximal because it's muscle related problem only. So it's still proximal more than distal, but more prominent is sort of a girdle weakness will be there, in that the hip girdle will be affected more than the shoulder girdle. The lower limb weakness will be prominent in these patients. And apart from that, if you take the deep tendon reflexes will be normal, we know that in the setting of myasthenia gravis, where it will be suppressed in limbs. That's a very characteristic finding. And apart from that, go for investigations. If you do repetitive nerve stimulation, Lambert-Eaton myasthenia gravis will show a decremental response, whereas limbs will show some sort of an incremental response, because the conduction will be more if there is more depolarization passing through the perisynaptic terminal. So more of them, they will get an incremental response here. And as far as autonomic features are concerned, bladder and bowel involvement will never be a feature of myasthenia gravis. It can be still a feature of a Lambert-Eaton myasthenic syndrome. And exercise, for example, if you take the diurnal variation, you know that evening weakness will be more than morning weakness in myasthenia gravis patients, whereas here morning weakness will be more than the evening weakness. Here exercise worsens. Here exercise may show a transient improvement. Even in electrodiagnostic studies, they may have a transient improvement. So treatment is completely different. In myasthenia gravis, you know what the treatment you're going to do. In limbs, you have to treat the underlying cancer, even though certain drugs like 2,3-dihydropyridine has been used in the setting of Lambert-Eaton myasthenic syndrome, but it's not very good. So treatment of the underlying cause is going to be the most important in the setting of a Lambert-Eaton myasthenic syndrome. Mostly it is to treat the paraneoplastic syndrome, that is the small cell lung cancer. All right, so we know now the neuromuscular junction disorders also. With this, we are completing the neuromuscular junction disorders. Then I think I'll leave you for lunch after the muscular dystrophy, because there are some muscular dystrophies that you need to know for exams. Some important variants are there. What all is important for exams we'll discuss, because again, this is a very big topic, muscular dystrophy. But you need only certain things to know for exams to just make a diagnosis in exam. That's going to be most important. So in that setting, first thing what we denote is that Duchenne muscular dystrophy. That's the most important, DMD. And we know Duchenne muscular dystrophy is an X-linked recessive disorder, and it is due to mutation in the dystrophin protein. I mean, dystrophin is something that is needed to anchor the muscle properly. It's sarcolemma properly, and it's like a structural protein for the muscle. So the muscle will collapse if there is no dystrophin. So dystrophin mutations are the reason. And as far as DMD is concerned, once again, you know the proximal weakness is going to be more than the distal weakness, because it's a muscle disorder. And most importantly, at 10 years of age, the patient will be completely wheelchair bound. But in the initial stages, before they become wheelchair bound, you can see certain important features like Gower sign. Remember, Gower sign is not specific for Duchenne muscular dystrophy. It is seen in any condition that produces severe proximal myopathy in children. That's what we call it as Gower sign. So, like what is Gower sign? The child, whenever they're lying down, they try to get up by supporting their knees. So by keeping their hands on the knees, supporting their knees, the child tries to get up. So that's what we typically call it as a Gower sign. It's a sign of a severe proximal weakness in children. It is not specific for Duchenne muscular dystrophy. And many patients will have cough pseudohypertrophy. That is due to fat replacement. The cough may look falsely hypertrophied despite the severe weakness will be there. That's called cough pseudohypertrophy. Again, it's not a specific find. It can happen in many other muscular dystrophies. At the same time, this can also happen in setting of hypothyroidism. And so many conditions are there which can cause some storage disorders. Trichinella spiralis also can as associated with cough pseudohypertrophy. But it will not be asked in exam. Causative hypertrophy in children exam means DMD only, but just for your understanding, I'm telling it's not a very specific problem to be seen. And many patients tend to have a waddling kind of a gait. That is again due to severe proximal weakness in these guys. And within 20 years, they will die. Death will ensue. And they will not survive beyond 20 years. And that is because the patient develop respiratory failure, which is the most common cause of death. Apart from that, second most common cause of death is cardiomyopathy. Many of these patients will be having associated cardiomyopathy, which can be either dilated type or restrictive type. Whatever you want, you can tell in exam. I will generally write a dilated cardiomyopathy, but if you want, you can write a restrictive. Both can be caused by Duchenne muscular dystrophy. And as far as the investigations are concerned, DMD, you are going to have significant elevation in the CPK because of the destruction of the muscles. Even though at very late stages, you will not have that much CPK elevation. But one of the characteristic features is severely increased creatine phosphokinase. And the gold standard is going to be the biopsy only, because this is a dystrophic disease. It's a congenital disease and there is no ongoing inflammation. And typically you will see reduced number of muscle fibers with absolutely no inflammation. And the muscle fiber size will be small and they will be going for death. But there will be no inflammation or necrosis in the muscle. And there will be increased fat content compared to that of the usual muscle biopsies. So this is really important because of two reasons. One is you can now understand why steroids are not helpful, because they will not reduce the progression of the disease. So number one. And second is, it is important to differentiate from other muscular disorders like idiopathic inflammatory myositis, where inflammation is the classic finding. So they can also produce proximal myopathy. So in children also there is juvenile myositis and all is there. So differentiate that particular entity. Your no inflammation kind of a finding is very important. Even there are some stains also which are used to, which can identify the dystrophin, but currently it is not important. IHC is also there. Treatment wise, there is absolutely no treatment available, but you can try glucocorticoids. We don't know how glucocorticoids work, but they can produce a transient improvement in the disease, maybe for a year or two. That is just due to, probably thought due to some anabolic effect of the steroids, where they try to increase the proteins a little bit. So maybe, possibly, some glucocorticoids can be tried, but still it's not going to be of much use in the longer run. Anyway, the mortality will not be changing. Transient improvement in power alone can be there, but of course, you will not get much improvement. There is no real treatment right now for Duchenne muscular dystrophy. Only genetic therapy is the future. If there is some improvement in genetic therapy, then it can work. Otherwise, it won't work. So the most important points here being, within 10 years, they'll be wheelchair bound. This is going to be the most important point as far as the Duchenne muscular dystrophy is concerned, because that will help you in differentiating from many other types of muscular dystrophies like Becker muscular dystrophy. It's the same problem, X-linked recessive. It's also dystrophin disorder, which means everything is same, but the amount of dystrophin that is lost is lesser compared to the Duchenne muscular dystrophy, which means compared to Duchenne muscular dystrophy, they're going to have a relatively slower progression. They don't have a faster progression, which means they will be wheelchair bound only by 20s and 30s. In 20s and 30s, Duchenne muscular dystrophy patients would have died by that time. So which means in an exam, if they give any child who's walking after 10 years of age, or if any person who's alive after 20 years of age, or if anyone who's walking and not in a wheelchair after 10 years of age is not Duchenne muscular dystrophy, and in that setting, usually it goes towards a Becker muscular dystrophy only. Still, these patients also can have cardiac involvement, and they can show cardiomyopathies can be present in these patients also. And usually, again, the most common cause of death in these patients also will be respiratory failure, and the second most common cause of death will be cardiomyopathy only. But it's just the fact that this point is going to be the most important in these patients. The slow progression is the only thing that differentiates Becker muscular dystrophy from Duchenne muscular dystrophy clinically. Apart from that, everything else may be extremely similar, including biopsy, CPK levels. Everything is absolutely similar. And again, it has no treatment. And next we have Emery-Dreifuss. We have Emery-Dreifuss type of muscular dystrophy. The most important point that the examiner likes to emphasize in Emery-Dreifuss dystrophy is more of a normal CPK. These patients does not tend to have higher CPK, or they can have a mild increase in CPK, but will not have a significant amount of increase like what you see in Duchenne or Becker muscular dystrophy. And second important point that the examiner tries to emphasize in Emery-Dreifuss dystrophy is the patients will not have this kind of calf pseudohypertrophy. And they also tend to have more of proximal weakness. Only I'm not telling they'll have distal weakness. They can be again children to young adults. Very commonly, only these people will be affected. And another thing that characterizes this Emery-Dreifuss dystrophy is the contractures they get, which is uncommon in DMD and BMD. It can still be possible, but the contracture will be very, very severe in Emery-Dreifuss. Typically happens in elbow and ankle. Contractures, elbow and ankle is extremely common. Apart from that, these patients may also have proximal weakness, and these patients can also have cardiac involvement. So that will not differentiate this from Duchenne muscular dystrophy. But the first 3 points I told you, CPK, no calf pseudohypertrophy, that specific point, and presence of more contractures. If they emphasize more on these 3 points in a child or a young adult with muscular weakness, then you can go towards a diagnosis of Emery-Dreifuss dystrophy in exams. Then you have something called a LGMD, that's called a limb girdle muscle dystrophy, or otherwise simply called as a limb girdle dystrophy. There are multiple different types of LGMD are there. But typically, to be honest, once again, limb girdle dystrophy tend to have a normal or only mild elevation of creatine phosphokinase. And once again, they do not tend to have calf pseudohypertrophy. And the contractures will be rare. And on the other hand, they will have only girdle weakness. They typically give only girdle weakness. There is no other weakness, no other problem. This will be usually around 18-20 years children. I mean, that is the time where LGMD commonly presents. Inheritance pattern is it's quite varying, but autosomal dominant type of pattern is very common in limb girdle muscular dystrophy. Apart from that, if isolated girdle weakness, shoulder and hip girdle alone, no other weakness, no calf pseudohypertrophy, normal or mild elevation in the CPK, that is suggestive of a limb girdle muscular dystrophy. Very common thing in exam. Because they wanted you to test, because they'll give a child around 18 years, 19 years, walking and coming to the OPD, having predominantly girdle weakness alone, and there's no calf pseudohypertrophy, only mild increase in the CPK or normal CPK to be precise. You go for LGMD because it cannot be Duchenne, because the patient cannot walk by 10 years. In Duchenne, they cannot come walking by 18 or 20 years of age. And of course, predominant girdle weakness alone is not a feature of Becker's muscular dystrophy also. And calf pseudohypertrophy is a feature of Becker's muscular dystrophy. It's a Becker's, definitely you'll have an extreme elevation of CPK. If all these things are not there, you answer a limb girdle muscular dystrophy. That's how you construct a differential diagnosis. And there are many other types are also there, like oculopharyngeal dystrophy is there. And girdle means shoulder and hip girdle, girdle weakness. This is girdle, shoulder, only shoulder. Not proximal means this also will come under proximal. But girdle weakness means only shoulder and hip. That's all. Only the muscles surrounding that region will be defective. For example, these patients will have prominent defect in abduction and probably elevation of the shoulder. Apart from that, all the other powers may be completely normal, and they don't have any sort of distal weakness whatsoever. But if you take a patient with a DMD or a BMD, I told you it's a proximal weakness more than distal weakness. It doesn't mean they only involve proximal muscles. It's a proximal weakness that is more severe compared to the distal weakness. It means that weakness will be distributed elsewhere else also. You will not have only the proximal muscle weakness. And oculopharyngeal dystrophy, which means here, as the name suggests, the patient will have weakness only of the eyes and the pharynx. Most of the time, this will confuse with other forms of disorders like myasthenia gravis. And once again, you know how to diagnose myasthenia gravis, so it's not going to be a big deal. And one important problem is they come in the 60s and 70s. Which means it comes in elderly, oculopharyngeal dystrophy. That's the important point there. So you can confuse an exam with myasthenia gravis, but there won't be fluctuating weakness. There won't be something sort of acetylcholine receptor antibody positivity, or there won't be any kind of thymoma in the patient. There won't be fluctuating weakness. There won't be diurnal variation. So that will help you to differentiate this disorder from a myasthenia gravis, because myasthenia gravis also has a second peak in the elderly, 60s and 70s. And you have a facioscapulohumeral dystrophy. Once again, it happens in teenagers, around teens and young adults, adolescents. Typically, you will get this FSHD, that's called a facioscapulohumeral dystrophy. As the name suggests, if exam question tells you predominantly winging of the scapula alone, bilaterally. Unilaterally means you can think about some brachial plex injury or that long thoracic nerve of bell injury. Bilaterally, symmetrical weakness, because myopathies and muscle disorders tend to be symmetrical. I told you already. Myasthenia gravis tend to be asymmetrical. That's also one big clue for your exam, from exam point of view. So now you have a bilateral winging of the scapula and patients having facial weakness alone, a teenager, 15, 18 years, only winging of the scapula with severe facial weakness. Of course, the diagnosis tells you it is a facioscapulohumeral dystrophy. And then, of course, have proximal weakness, but the proximal weakness will be more concerned with the shoulder and the arms only. So, shoulder girdle weakness, winging of scapula, bilateral, symmetrical, facial weakness, FSHD. It cannot be anything else. And finally, before going on to the lunch, I will try to finish off this thing only. That is how to differentiate between a myopathy and a neuropathy in a EMG. Remember, as far as EMG is concerned, even though the tracings are important, I believe EMG is more of your sound, the hearing that you make. That's the more important thing in EMG. So let us take two groups of muscles and different motor units. I'm drawing here. I mean, it's a very tough area, but I'll try to simplify as much as possible. But it's really, really tough to understand. So three groups of muscle fibers are there. For example, red fascicle and this kind of blue kind of a motor unit or a fascicle, and this brown, probably whatever it is. So this blue, this red has some amount of muscle fibers, and this blue has some amount of muscle fibers. Let us assume, and this brown has another type of group of muscle fibers. So let us assume you have a red neuron that is supplying this particular motor unit, and you have a blue neuron that is supplying this motor unit, and you have a brown neuron that is supplying this particular motor unit. And let us consider this is normal. And what happens in a neuropathy? In a neuropathy, the same thing I can draw here. So the number of muscle fibers will be the same. It will not change because it's a neuropathy that you're talking about. And it's not going to change, by the way. But the axons are going to be less. We're talking about an axial neuropathy to start with. The axons are going to be less. For example, what really happens in this setting is, for example, you lost the blue and the brown axon, which means you have only the red axon. Now, in acute settings, fine, there won't be any change. But in a chronic setting, these axons are going to sprout out, and they're trying to supply the other fascicles and other motor units also. But this is going to be really inefficient, where it's like channelizing the power to three different in a series line. That's in parallel, it's fine. But if you're doing in a series connection, three different circuits are channelized now. Of course, you not get a good power in any of these three. So that, I mean, you can try to contract a little bit more. Weakness might improve a little bit better, but again, it's not good, and you're not going to get a sufficient power in this setting. So that is the reason why neuropathy also has a weakness. But this is quite inefficient way, but they at least try. Unlike most of the like humans where they give up, at least the neurons are trying to do something. That's what happens in the setting of a neuropathy. But if you take a myopathy, on the other hand, a muscle disorder, the situation is going to be quite different, where your neurons are okay, but more often you don't have sufficient amount of muscle fibers. The fascicles are not having muscle fibers at all, but the neurons are okay. In a pure neuropathy, right? In a pure myopathy, your red neuron is still there, what I've drawn in the example, then your brown neuron is still there, and again your blue neuron is also still there, as per the example we have seen. So what are the things you will look at in the electromyography as far as EMG is concerned? Number one, you're going to put a needle inside the muscle, right? So this is what we refer to as a needle EMG. So let me draw the needle in a different color. Maybe I can put this. So you're inserting a needle here, So whenever you put a needle into the muscle, when you are pushing the needle, threading a needle into the muscle, of course, the muscle will have pain, isn't it? And they're going to cry out of pain. And that kind of crying activity is what we refer to as insertional activity. Nevertheless, if you want to know, I mean, even though analogy is good, but if you want to know about insertional activity, it's quite simple. When you go into the muscle, you're going to tear off some muscle fibers, of course. When the muscle fiber is teared off, because through and through it will pass, there will be leakage of potassium from the muscle. Muscle is a very rich source of potassium, and that leakage of potassium is what we hearing as that crying of the muscle. That how it will exactly look like is when you crumble a paper, you'll get some kind of a sound. The same kind of a sound you will get in the EMG machine. So that's called as insertional activity. So we have a normal insertional activity here. And when you go for a neuropathy, again, the insertional activity is going to be quite normal because the number of muscle fibers is the same. And the amount of muscle fibers that they're going to traverse when you put a needle is the same. So there's no much difference. So the insertional activity will be completely normal. As far as myopathy is concerned, when you put a needle, you can see as per this example, because the muscle fibers are extremely sparse here, when I put a needle, amount of muscle fibers that are going to be broken or teared is going to be quite less, which means there itself I can find out my insertional activity itself will be very much diminished in the setting of a myopathy because the reduced number of muscle fibers. And second point is there is something called as a recruitment phenomenon, or we have something called a motor unit potential. That's what we need to see here. So what do you mean by motor unit potential? That is MUP. So when you ask the patient to do some exercise or when you ask the patient to do some activity, the number of motor units that are recruited will be more. So for that, you need to understand what you mean by recruitment. Recruitment and motor unit potentials. Clear? So recruitment and motor unit potential. So first we'll talk about recruitment in that setting. So what do you mean by recruitment? So first, let me ask the patient to, I mean, this is an only understanding, but real time we don't do that. So for example, if you are lifting only probably 500 grams of weight. So to lift that 500 grams of weight, only this blue color motor unit is enough to lift that 500 grams of weight. So only this neuron will fire too much and others may be silent. And after some time, if you give 1 kilogram to lift, then these two motor units will now getting recruited. So second motor unit is also there. Now if you give 5 kilogram of weight, now all these three things has to fire in unison to produce that kind of activity to lift up probably 2 kilogram or 3 kilogram of weight. So this phenomenon is what we refer to as recruitment. So more and more motor units will come into action. So that's called as a recruitment. So how to understand this recruitment? So recruitment, and third thing is something called interference is there. So what do you mean by recruitment? What do you mean by interference pattern? So if we talk about recruitment means, so the number of different motor units. Myopathy will need excess fibers to lift a small weight. Yes, that's what I'm talking about. So what do you mean by recruitment? And what will be the motor unit potential? That's called MUP. So all these three things we are going to see. What will be the motor unit potential? So as far as recruitment is concerned, in neuropathy, the recruitment will be happening very fast. I mean, the sense like recruitment can be normal entry. I mean, the sense like interference may be normal. And in fact, recruitment will happen much early. And interference will be completely normal because these all three motor units are firing in unison. Oh, sorry. Interference will be reduced. Interference will be different. Why? Because now all these three motor units are behaving as one single functional unit. Like this particular axon is the one that is actually supplying all these three motor units. So which means you'll be seeing only this one kind of potential. The same kind of potential will be there, irrespective of whatever may be the weight you give. So which means I can see only one kind of potential that is happening throughout the testing process. And what will happen is the potential will be huge because it's only at every point, even at a lower point, all these three motor units are firing in unison. So in a chronic neuropathy, all this behave as a single motor unit, even though they are separated by numbers, like there'll be a single motor, they'll be functioning as a single motor unit only, even with a smaller weight, everything is going to fire at once. and the potentials will be very high. The motor neuron potentials will be very high, so they're going to produce bigger complexes like this. So normally how you are going to produce, in the beginning you will have, for example, only the blue ones. Later on, as you move to a higher weight, you will be getting something like this. You will get a blue one. Along with that, you will start getting, I don't have green, isn't it? You will start getting this brown ones. They will start firing. So you'll have a lot of interference in that, but the potential will start increasing. After that, your red ones will start firing with more weight. So which means your potential will increase. So this sequential increase in the potentials will be there. So this process is what we refer to as recruitment. And you can see more disturbances as you move on with increased weight. This is what we refer to as an interference pattern. This is what is going to happen in a normal setting. But in the setting of a neuropathy, even at lower weights, you will recruit all the motor units. So recruitment will be much early. And at the same time, they'll be producing more of a monophasic potentials. The interference will be more less because all the motor units are now acting as a single motor unit. And the interference pattern will be less. Interference will be decreased because everything is doing together, not different times. And as a one motor unit, they are behaving. So the potentials, motor unit potentials will be a little high and the recruitment will be a little low. And in the sense like interference will be a little low and recruitment will be more early also. As far as your myopathy is concerned, once again, the recruitment will be much early because they need all the motor units to fire in unison to lift even a smaller weight. But the interference pattern will be normal. It will be having a normal interference, but at the same time, the motor unit potentials also will be reduced. So which means here, you will get the similar sort of an interference, which means the background interference will be okay. But at the same time, the amount of amplitude they can produce will be very, very less. So which means all the three are firing, but very early they are firing. But the amount of potentials they can generate is very less because number of muscle fibers here are very less. But the amount of, compared to the normal, where the potential is very high, but here it will be early, very less potential, but they'll have a normal interference. Sometimes even they can have an increased interference also. That's what some books will tell, but I believe it's a normal interference. So fluctuations will be too much, but amount of potential height they can produce is very less. At the same time, they will have an early recruitment as well. So this is going to be the most important. Reduced interference and higher MUPs and early recruitment, neuropathy, especially chronic neuropathy. Early recruitment, normal interference with reduced motor unit potentials is a classic feature of a myopathy. And more importantly, fasciculations and fibrillations. This can be seen in like EMG also, but more classically, fibrillations are the ones that is typically seen in EMG. Fasciculations is a clinical finding, which is typical of anterior cell damage. But nevertheless, fibrillations are very classic features of neuropathy only. It will never be seen in myopathy. So why fibrillations are happening? Again, a lot of theories are there, hypotheses are there, but basically fibrillations can happen whenever there is a denervation supersensitivity. So which means this blue, in this particular example which I've told you, this blue color motor unit and this brown color motor unit is actually, even though the other axon is trying to supply to an extent, but they'll be having denervation supersensitivity, which means there will be upregulation of the receptors. For example, acetylcholine receptors will be there, and there will be upregulation of the acetylcholine receptors in this setting. Because there are upregulation of the acetylcholine receptors in these two motor units, there will be something called baseline firing. I told you every axon has a baseline firing. So this axon also produces a baseline firing. And this motor unit that is normal, okay, not a problem. But this baseline firing will go to these two motor units also, that is on the sides. And because of the denervation supersensitivity, and even at baseline, the small amount of acetylcholine that is coming, baseline firing that is coming from these neurons is sufficient enough to produce rapid fluctuations at the baseline level itself. So that is what we refer to as a fascic fibrillation that is seen typically in the setting of a peripheral nerve damage. But in myopathy, there's nothing like that. So these neurons are okay, only the muscle fibers are reducing. So there is no denervation supersensitivity here. So the amount of acetylcholine receptors will be normal. And in fact, you cannot produce fibrillation. How can you produce? If all muscle fibers are reduced, you cannot do that. So of course, 100% it's not possible to have fibrillation in the setting of a myopathy. And in neuropathy, you will get fibrillations. So presence of fibrillations, early recruitment, reduced interference, and increased motor unit potential, sign of a neuropathy. No fibrillation, reduced motor unit potential, normal interference, and early recruitment is again a sign of a myopathy. And again, if they talk about insertional activity is reduced in the setting of a typical myopathy and not in the neuropathy. So these are very classic findings in the EMG. Even though it's quite difficult to understand, I think I've tried my best to explain this in an easier way. So in exam, I mean, definitely they'll be telling you some clues regarding the EMG, whether to diagnose at least a neuropathy or a myopathy. And one thing is there, one time of myopathy we didn't describe. So that is very important. So that's called a diver bomb sound. So in a myopathy, if they give something called a diver bomb sound, where will you get this kind of diver bomb appearance? I mean, a diver bomb sound. So, I mean, remember myopathy is more of a, like hearing. EMG is more of a hearing rather than seeing the figure. Seeing the figure is important. I'm not telling no, but most of the experienced people who listen to this EMG will be typically, like hearing the sound and diagnosing the disease. It's very easy to hear more than see. So where you see this diver bomb kind of a sound, put a needle inside, you'll get bomb sound. It's a big sound. So that happens in myotonic dystrophy, which means whenever there is a myotonia, you'll get a diver bomb appearance. That is because of simultaneous contraction of different group of muscles. Especially when the muscle is asked to contract, you will produce a huge sound in the form of myotonia, failure to relax. So that is what is going to produce a typical diver bomb sound, which means that also makes us to know that something called a dystrophica myotonica is there. That is myotonic dystrophy. This is also a type of muscular dystrophy only. You have two types, type 1 versus type 2. Type 1 is the most common and very commonly asked in exams. Type 2 is not very commonly asked in exam. Remember, type 2 is due to a completely different problem. It's a tetranucleotide repeat disorder. It's a CCTG repeat disorder. And it's due to something called ZNF9 gene mutation. That's completely different. We don't want that. Whereas type 1 is basically due to CTG, trinucleotide repeat sequence, which you have seen already. And it's due to DMPK gene mutation. DMPK gene mutation, which is present in chromosome number 19. That is dystrophica myotonica protein kinase gene. So that is the gene mutation that happens in type 1 myotonic dystrophy. I think we have discussed the clinical features already as a hint I told you. But if you really want to know the clinical features, very classic in exam. Typically, the first feature is myotonia. It means inability to relax. They hold the hand, but they cannot leave it because contraction will be there, but they cannot relax. So that's myotonia, classical finding. And this myotonia can be seen in many areas, but typically in exam, they'll give a clinical sign called a percussion myotonia. So what do you mean by percussion myotonia? Especially, it's done in the thenar eminence. In AIMS questions, they commonly ask this. In thenar eminence, if you try to percuss, the muscle go for contraction and it will not relax. So this is what we refer to as a percussion myotonia, very common sign in exam. Then they'll of course have weakness, and it will be more of a distal more than a proximal weakness. Distal more than a proximal weakness. And number 3, they'll have other associated findings like like myotonic facies. The characteristic myotonic facies will be there. Like for example, there will be a bilateral facial palsy. Not facial palsy. You think about it's a facial nerve. Then it's a facial muscle weakness, not a nerve weakness. They'll have a bilateral facial weakness, and apart from that, they'll be having ptosis, which will also be bilateral. Coupled, because of the ptosis and the facial weakness, they will be showing a kind of an innocent face like this. They may or may not be innocent, but they'll have some kind of an innocent face because of the bilateral facial weakness and ptosis. Very difficult to see in expressions. One of the important cause of mask-like face as well. And they can have a cataract. So you know what is the type of cataract they will have? That's a typical Christmas tree type of a cataract. And that's trivial, and nobody's going to ask those questions in exam, by the way. And apart from that, they can have dysphagia. 30% of the individuals can have dysphagia as well, and they can have diabetes mellitus, and they can have cardiomyopathy, and they can have reduced fertility because of testicular atrophy, and because of that hypoandrogenism, they'll have gynecomastia as well. Gynecomastia is due to hypoandrogenism in these patients. So classical features of myotonia dystrophy. I mean, usually some of these findings will be there in these patients, but usually clinching point will be this myotonia. So that in EMG will produce this kind of a diver bomb sound, which is going to be very important. I think we have discussed about the important aspects of muscular dystrophy, myopathy, and neuropathy. I think next session will be the last session on neurology, where I'll try to discuss on Parkinson's disease and dementia. And probably if there is time, I'll discuss on seizures also. With that, neurology will be over. After neurology, we'll discuss on what to be done in the post evening session. Okay. You can go for lunch and come back by 4:15 maybe. So I think you can start by 4:15 to 4:20 or some 4:30. You can give some extra 10 minutes questions. So go back and come. Bye-bye.